Earlier connected.
Jyoti.
Oh,
I'll change the background.
it's Jyoti Matalia, but it is showing as Himanshu. Maybe she's presenting from his Zoom link. I don't know. Dr. Pradeep Sharma said he'll join by 7. Dr. Jaspreet has not yet joined. Dr. Suma Ganesh has not yet joined.
We are live, ma'am.
Okay. Yeah. A very good evening to one and all of you in this very nice webinar, a very interesting webinar it's going to be, and very, very relevant to the those in pediatrics and strabismus. And we have the best of expert panel here with us and a great set of speakers. And I'm sure the 2.5 hours would we lock in is going to be all absorbing. Joining us very soon is going to be Dr. Pradeep Sharma, who had a long stint as a professor and head of the Pediatric Ophthalmology, Neuro-Ophthalmology and Strabismus at RP Center. And but now recently he's into heading the same sections under the CFS banner. Joining us soon would be Dr. Rohit Saxena, who is again the professor of ophthalmology and from All India Institute of Medical Sciences. And joining us soon would be Dr. Jaspreet Sukhija, who is again an associate professor of PGI Chandigarh, and I'm sure we are going to learn a lot from him with us. And we are very happy to have with us Dr. Savleen Kaur, who is the assistant professor in the Department of Ophthalmology, PGI Chandigarh. And thank you very much for your presence here with us. Joining us soon is going to be Dr. Suma Ganesh, who's the Deputy Director, Chairperson and Head of Pediatric Ophthalmology and Strabismus from Shroff Charity Eye Hospital, Delhi. We are truly, truly happy to have with us both the Meenakshis, the Duans of ophthalmology and especially pediatric ophthalmology. We have with us Dr. R. Meenakshi, who is the Chief Medical Officer and the Chief Pediatric Ophthalmology and Adult Strabismus Services from Arvind Eye Care Systems based at Tirunelveli. And we have with us Dr. S. Meenakshi, who had a long, wonderful stint at Shankar Nethralaya as a senior consultant at head the department and was having a very major role play in the postgraduate training program, which she so meticulously, so passionately kept it all together. And she's a national figure of great repute, and we are truly delighted to have her with us. And now she's into her own private practice, and we wish her a great, great future ahead. Moderating along with me is Dr. Murlidhar, who's our senior consultant in cataract, glaucoma, pediatric, strabismus, neuro-ophthalmology services. That's what he is. So multifaceted and so contributing to our Eye Foundation group of hospitals. And I look forward to his major moderation during the course of this webinar. We shall start with our first speaker, Dr. Fatima, who is a medical consultant for pediatric ophthalmology and adult strabismus from the Arvind Eye Care Hospitals, Tirunelveli. And she is going to talk to us about supported IOL implantation in pediatric ophthalmology, my take. I think it's a very important topic. Let's all hear from her. On to you, Dr. Fatima.
Thank you, madam. Thank you for this wonderful opportunity. I hope my slides are seen.
Yeah, it is seen.
Yeah, good evening, everyone. The supported IOL in pediatric ophthalmology. Yeah, because of the restricted time, I will just, with very little introduction, we know the indications for supported IOLs. It is in the form of modified CTR, CTS, and in iris fixation or scleral fixation IOL. So first we will go through modified capsular tension ring segment. Always it is a concern in a pediatric for pediatric patients about the long-term result. Here is an encouraging report in AJO about 101 eyes, where the second surgery was warranted only in 4 eyes, and there was no report of dislocation. Then our data, if we see, we have operated 30 eyes, age ranging from 4 to 15 years, and month of follow-up 1 month to 4 years. More we did in past 2 years. That is why the average duration of follow-up is only 12 months. And our result is 83.3%, more than 6/9. So let me, for most of the cases, we operated with supratemporal subluxation, where we make corneal entry in the supratemporal aspect. That would be easier for us to introduce the Sioni capsular tension ring. And if the subluxation is temporal, we prefer temporal entry. And if it is superior, superior entry. In case of nasal subluxation, as we cannot make nasal entry, we go by superior entry. And always we know rectus is the key factor for further steps. And how much ever experience surgeon has, it is better to always give guarded prognosis to the parents about the possibility of leaving the eye aphakic. Only then maybe it will take care of our stress factor also for the surgeon. And if the things go well, and the surgeon will get good credits from the parents as well. And very much care so that it will not go outside. Actually, it is better to start with rectus even in lensectomy cases. That's how I started. I have observed my chief Meenakshi madam, who does even in rectus, even in very gross subluxation of lensectomy cases. So it is possible in most of the cases. And next step would be the making a pocket to keep the sutures in suture ends inside. It may be Hoffman pocket from cornea to sclera, or if one finds difficult to make a long pocket, one can do a small reverse scleral pocket so that it will be easier. Then the remaining steps will be passage of needle with suture. Usually we prefer 9-0 suture, and the suture is threaded with the Sioni is threaded and inserted, and the more care has to be taken to avoid entanglement of the suture. So if we see here about the type of Sioni CTR, there are R model and L model, depending upon the position of the hook. Only thing we have to take care is the orientation has to be maintained. This is the nasal subluxation of 2 different eyes. Here, right model is used, so this portion has gone in first. And here, left model is used, so this portion, that hook portion, will go at the end of the thing. Usually, nasal subluxation will need hooks to stabilize the bag, because it is not that easy to take the whole thing inside. That is a big challenge in handling nasal subluxation. So as an alternate to nasal subluxation, we can see here it is a dramatic case. Here we through paracentesis we can introduce a capsular tension ring from the opposite aspect, and we can have capsular tension segment there. Here it is held by the assistant to support the bag while introducing the capsular tension ring. So coming to iris fixation IOL. Usually for secondary IOL, we prefer scleral fixation IOL. In such case where there is a big scar and the pupil is mid-dilate fixed, visibility is poor. So the one we do often in adult cases, the iris fixation is being done here. Here sutures are passed through and through iris, and the suture loop is brought out. And it is looped several times over the haptics, both the haptics from both the sides. The advantage here is we can take the leading haptic inside and under the iris and tie it first before we position the trailing haptic under the iris. So because there is no support in this eye, so we prefer doing like this. And here now, while taking second haptic, we cannot dial the IOL. We have to carefully take it beneath the iris, leave it, and suture the haptic over with the iris. Coming to scleral fixation IOL, this is the technique I prefer. X-net here using a 15-degree paracentesis blade, a scleral pocket is being made, and we can use AC maintainer because it's a secondary IOL patient where there was a vitrectomy already done. It was a hypotonic eye. So the two pockets are being made exactly opposite, and usually I make a small nick so that I will get a working space to introduce the haptic. That is the most stressful step. And for leading haptic, we can even dock in while the needle is inside. And the major advantage of this extended procedure is the stopper provided with it. And the trailing haptic is introduced safely by exteriorizing the needle out. And now the haptic can be docked in using micro forceps. And we can titrate by adjusting the position of the haptic. Thank you. I'll conclude with that.
Thank you very much. I have one question for anyone in the expert panel. Many of these patients could be very young, and in young patients, you all would do a posterior capsular rexus. So how can you place a Cioni ring and do a posterior capsular rexus? So that means Cioni rings are going to be placed only in older children. And the other question is, what are the rates of PCO? Normally, they say when you place a PCTR in an eye, it's one of the reasons is it prevents PCO formation. So does the Cioni ring actually help at all in these situations?
Yes, madam. This is the main question everybody, looks for. Actually, the minimum age is 4 years of us. What we have observed is definitely the Cioni CTR delays the formation of posterior capsular opacification. By the time the opacification forms, the child becomes cooperative for yak capsulotomy. And what we have found out is it is very safe to do yak capsulotomy with Cioni capsulotomy ring in situ. And even in that study, 101 eyes that they have mentioned, they have comfortably did many yak capsulotomy, but we have never tried posterior rexus on table because with great effort after placing everything, taking risk, we have never tried. So maybe there are studies where they do vitrectomy. Even in that study, some cases underwent PCC using pars plana route. Maybe that would be one option. But what we have observed is we have not faced with a very thick PCO that will not be handled by that kind of issues didn't happen. We are able to manage with the capsulotomy, and definitely the PCO formation is delayed. Unlike other pediatric case where if we don't do PCC, we will see PCO at once.
Dr. Sujata, would you want to add anything here? You have to unmute yourself.
Yeah, sorry. So I absolutely, the question is extremely a very well-founded question. And yes, after the age 4, the PCO is not that dense. So I think the yak capsulotomy would be able to cut most of the PCs at that age group. But a little younger child, I would actually hesitate to do the procedure without doing a posterior capsulotomy, or maybe a capsulotomy can be done from the pars plana route if possible. But my concern is these are all proline sutures over a period of time, and these are 4-year-old children and 5-year-old children. Over a period of time, we have seen many of these sutures giving way and the lens dangling in all of these sutured procedures. So that could be a concern as the child grows older into adulthood. I mean, after 10, 20 years, that could definitely be a concern.
Yes.
Can I make a point?
Yes,
Dr. Jasprit.
Yes. So that's a very valid point Dr. Sujata has brought forward. But there's no other option here. I mean, what would you use? Gore-Tex sutures, that could be used. Now the Yamane technique, which people are using in adults, I mean, without using sutures, if you use them in children with a scleral elastic, it has a high rate of IOL tilting, in my experience. Okay, there are not many studies now out as yet in children, but yes, it is very important to note that there is IOL tilting in these patients. Coming to the ectopia lentis, what the presenter has very beautifully highlighted, you have to know the etiology as well. Because it's not just the amount of subluxation which matters. Now, if supposing you have a patient with Marfan syndrome where it's you can say a progressive disease, if you place this along with the proline sutures, you're doing a TSF IOL or you have proline sutures attaching that, it is ultimately not going to last long. First of all, it's a progressive disease. You're tying it on a sclera where the sclera is thin. So all these issues come up. Probably a better option in those would be a posterior iris claw lens. So not just the amount of subluxation, the etiology also matters. Then you have in simple ectopia lenses, it might be a good option. Where you have ectopia lenses at pupillae, where you have a lot of iris atrophy, there you cannot do an iris claw or an iris sutured lens. Probably you will have to go back to the scleral fixated lenses. So there are different scenarios in children. It's not so simple. I mean, you have to take into consideration, you can say a holistic management has to be done, taking into account the etiology as well.
Yes, very rightly said. Dr. Murli, you have a question?
Yeah, I have a question for the panel, and of course, Dr. Fatima also. So, would you pre-place the sutures before dialing in the CONE, and would CTS be a better option because the surgeon, especially the beginners, could get confused between the right and left CONE rings? So, would CTS be a better option? I mean, any
yes,
particular reason why you prefer CONE over CTS?
Yes, sir. CTS, the particular reason is I feel CONE ring is getting pulled along with the ring. That hook is being pulled, the whole ring is being pulled. Whereas CTS, that only one segment is pulled. So that is one concern.
No, CTS, that along with CTS, once we place the CTS, we put in a CTR also.
CTR also, but the angle of pulling, I mean, it
I could answer
just
that
one 4 clock
Yes,
hours,
Dr. Savlin,
one quadrant.
What we want is a circumferential, distribution of forces. So a single CTS is not an option. Even 2 CTS has been described in a patient, and the ideal scenario this described is, as Dr. Muralidhar said, CTS with CTR. But 4 CTS would, like, the ideal scenario is very, very difficult, and it's becomes very cumbersome. So CTS isolated will not give you the circumferential, traction that we want. So it's actually not the ideal option.
Okay.
So but would you pre-place the sutures, or would you thread it after it is in place?
Sir, we will thread it and then introduce. And only tying will happen after placement of CONE CTR. And one more thing I wanted to mention is we always check echocardiogram and look for systemic signs whether the patient has Marfan's, and also we look for homocysteine level, and we rule out these 2 aspects before we plan for CONE CTR. And none of the patients had Marfan's typically fit in Ghent criteria to say it is Marfan's. So that is why we proceeded. And another aspect I want to highlight is the more we like to place IOL is because this amblyopic age, we feel that it gives a very good rehabilitation. We have cases of lensectomy and phakic glasses patients. So we feel this visual outcome is better than lensectomy patients. Maybe we have to properly study it. That is the main reason, the amblyopic age. And one more encouraging factor is all the studies says only decentration. There is no dislocation. So again, maybe once the patient reaches adulthood, we can go in and again refix it, recenter already the fibrosis would have set in. So we can refixate the bag using.
Yeah. Okay, understood. I think we shall go for
some proline suture or some other.
Okay. We shall now, Murli, shall we go on to our next talk?
Yes, madam. Yes, madam.
Yeah. Our next speaker is none other than Dr. Sujata Guha, who is again who heads the Shankar Nethralaya group of hospitals based at Calcutta, and is a very leading pediatrician and neuro-ophthalmologist from her part. And she's going to be talking to us today on what is the best procedure for a unilateral inferior oblique overaction with a V pattern.
No.
Oh, what?
No, I will be speaking on managing anti-elevation.
Yes, sorry. Managing anti-elevation inferior oblique. Sorry.
Yeah. Can you hear me? Is my slide visible?
Yes, yes.
Yes, ma'am.
Okay, so I shall be speaking about a very unique complication of inferior oblique anterior transposition. And before I actually begin the topic itself, I would like a short introduction of the inferior oblique, which is originates from the orbital floor, runs along the floor, gets attached under the lateral rectus and behind the equator. And because it is behind the equator, its action is elevation. And if we have overaction of the inferior oblique, we have over elevation in adduction and DVD. So in case we do have overaction, we have different weakening procedures like recession, like anterior transposition, like anterior nasal transpositions. And it is with these anterior transpositions that we have the complication of anti-elevation. So what is anterior transposition? It is when the inferior oblique is transposed anteriorly to a new location so that the new insertion of the inferior oblique is anterior to the equator. And by doing this, we actually have the insertion which actually changes. So the neurofibrobascular bundle, which is an inelastic tissue, which is in the posterior surface of the inferior oblique and the lateral surface of the inferior rectus, that becomes the ancillary origin. And if you can see, because this becomes the ancillary origin, a force vector which opposes elevation is created. So from an elevation, it is having a force which is opposing the elevation. And we have different techniques of anterior transposition of the inferior oblique. One is a modified Elliott-Nankin, which is a very popular technique in which the anterior and the posterior borders are sutured one behind the other, lateral to the lateral margin of the inferior rectus. And we have the inferior oblique and transposition with a J deformity, where the anterior and the posterior borders are placed at in the same level, along the level of the inferior rectus insertion. So here we like here I have shown, this is the inferior oblique, and this is the inferior rectus, and oblique being sutured at the same level of the inferior rectus. And this is the J deformity, which is actually causes the anti-elevation. So if you, what is anti-elevation? So this is a patient with an inferior oblique overaction with hyperelevation in adduction with a V pattern and a DVD. And for this child, we did inferior oblique anterior transposition with a J deformity. And post-surgery, if you see, there is a limitation of elevation in abduction. So, and in these patients, the forced duction test is negative, implying that it is not due to a mechanical restriction that this elevation limitation is there, but it is mainly a neurogenic response. And the anti-elevation, because of its fixation duress on in abduction, the contralateral elevator starts overacting, and they mimic a recurrent inferior oblique overaction. So this is the anti-elevation syndrome. So what are the factors which causes an elevator to become an anti-elevator? As I did mention that neurofibrobascular bundle becomes the functional origin, so it starts acting like the inferior rectus and causes anti-elevation. The more temporal the sutures are, the posterior sutures are placed in a comparison to the inferior rectus insertion, the more the anti-elevation effect, especially in abduction, because of the greater extorsion vector. And in abduction, the inferior oblique starts acting like an inferior rectus, so there is a greater limitation of elevation in abduction. And finally, inferior oblique anterior transposition creates a vector force which causes extorsion, and this extorsion can actually act as an anti-elevator. This beautiful paper by Dr. Mims described the main culprit for this anti-elevation, and he saw that in his series of anti-elevation syndrome patients, the more temporal the posterior fibers were sutured to the inferior rectus insertion, the more the anti-elevation. The more anterior these fibers were sutured, they also were causing anti-elevation, but the main culprit was the temporal splaying of the fibers. So how can we prevent it? We can make some modifications in our anterior transposition. Anterior nasal transposition can be done, and inferior splitting, which has recently been published by the AIMS group. So what are the modifications? As I was talking, we can bunch up the inferior oblique at its insertion and not allow the posterior fibers to be splayed or attached temporally. We can avoid placing the inferior oblique anterior to the insertion of the inferior rectus. We can suture the anterior posterior fibers just behind each other, or we can simply not suture the posterior fibers and let it hang loose posteriorly. Anterior nasal transposition is a rather strong weakening procedure. It can be actually done very effectively for DVD, and it has the advantage that it does not cause anti-elevation, because the neurofibrovascular bundle, which acts as the original insertion, which acts as the new insertion, does not have that tautness if we displace it nasally. And this newer procedure described by the AIMS group is the Y split of the inferior oblique, where the inferior oblique insertion is split into a Y. The posterior fibers are attached posterior, 6 millimeter posterior to the inferior lateral rectus of the lateral border of the inferior rectus, and the anterior fibers are sutured at a diagonal 2 millimeter diagonal to the inferior rectus insertion. So this causes laxity in the neurofibrovascular bundle, and thus does not cause anti-elevation. In case we do have anti-elevation, what can be done? We can do a nasal myectomy. We can actually cut the temporal sutures and let it fall loose, or we can convert the anterior transposition into a recession by retroplacing the inferior oblique. However, retroplacing and making it into a recession can cause a recurrence of the dissociated vertical deviation. So to summarize, for a DVD, if we are planning inferior oblique anterior transposition, avoid the J deformity. You can do an anterior nasal transposition or a Y split, which both of which are good options for severe inferior oblique overaction, or you can convert the inferior oblique anterior transposition to a recession in case you land up with an anti-elevation syndrome. Thank you.
Thank you very much, Dr. Sujata. That was a very complex topic you tried to make very simple. Murli, can you take the questions?
Yes, SG madam, what about unilateral, madam? If you have a patient with V pattern and a unilateral inferior oblique overaction, or a patient who has DVD more on one eye with inferior oblique overaction hardly present in the fellow eye, how would you manage that, especially for the unilaterals?
See, unilateral inferior oblique overaction is a little tricky situation. In most cases of these V pattern, we try to do bilateral with a differential one eye recession, one eye anterior transposition, something like that. Mainly unilateral inferior obliques we do for superior oblique palsy with inferior oblique overaction. That is, but in most other situations, we would actually titrate the inferior obliques in the two eyes, but do it bilaterally. Because over a period of time, the contralateral eye, which we haven't done, starts overacting, and we have to do it eventually.
Madam, when anti-elevation does occur, would you just retroplace the inferior rectus, inferior oblique, as you mentioned? Is there any role for an inferior rectus recession in select cases where?
Yes, sometimes when it becomes difficult to perform the surgery, the preferential choice would be actually retroplacing it and doing away with the anti-elevation. But you can, of course, do an inferior rectus recession also in situations.
Thank you.
Thank you. Anything else anybody would want to ask, or shall we go on to our next talk? Rohit, welcome.
Thank you, ma'am.
We shall now go on to Dr. Kavita Kalevani. Dr. Pradeep Sharma would join after 7. Please, Mulli, keep a track of when he joins so that we can ask him to give his talk too. Dr. Kavita Kalevani, who's a senior consultant in pediatric ophthalmologist from Shankar Nethralaya, Chennai. And she's going to be talking on making sense of the plethora of transposition procedures for sixth nerve palsy and how to choose. On to you, Dr. Kavita.
Good evening, ma'am. Good evening, everyone. I was a little taken aback. Let me share my screen, ma'am.
Oh, you were expecting Dr. Pradeep, yeah, and the next.
Okay. So I'm going to talk about how to choose when we have sixth nerve palsy as a presenting problem in a patient. So what would be the right transposition procedures? Now we have lots of options compared to olden times to choose from. So we know that when to operate is a basic of any nerve palsy, like after 6 months with 2 stable measurements. And palsy versus paresis is how we decide how to operate and which muscles, and staged approach is sometimes warranted. So in case of a sixth nerve palsy like this, where there is a total abduction limitation with almost -5 limitation, where the eye is not even moving up to the midline. So how do we consider surgical options? So magnitude of underaction, muscle sequelae over a period of time, the range of movement which is present, and the requirement for the patient, functional versus cosmesis. So the goal would be to improve primary alignment and to enlarge the binocular field whenever possible. So for paresis versus palsy, we see the abduction, how much it is, whether it is beyond the midline or not even beyond the midline. And when fourth generation test shows us whether there is a residual function of the lateral rectus or not, and saccadic velocity. So when we have a total sixth nerve palsy with complete absent abduction at all, with the total loss of function of the lateral rectus, we have a few options to choose from. A vertical rectus transposition, which is gold standard. We used to have this as a very good option. With or without Foster's augmentation, still date proves to be a very good option when there is no other, when there is the complete total sixth nerve palsy, or Jensen's procedure. So this is a patient who underwent a vertical recti transposition by superior and inferior. So these are the steps of the surgery. I'm not sure if it's clear, I couldn't get the video. So we see the lateral rectus hooked and the superior and the inferior rectus full tendon transposed to the lateral rectus, parallel to the, making it parallel to the lateral rectus, with the Foster's augmentation to augment the procedure. So this patient presented with bilateral total sixth nerve palsy after a medial rectus recession being done 3-4 months earlier. A full tendon vertical transposition with augmentation was done, and after the first surgery, and this is after the final surgery. So we see a very good alignment, even though abduction is not recovered fully, but he has a good primary position alignment. So there are multiple newer modifications where we can tackle both vertical recti, where there is augmented Hammershim technique, double augmentation of the same procedure, plication with Hammershim technique, and the latest modified Jensen's or the Nishida's technique. So here in the final procedure, there is a very less chance of ischemia, anterior segment ischemia, and there is even improved abduction. So a single vertical rectus transposition is also described nowadays, where you can do a medial rectus recession and only superior rectus transposition. So we don't have to stage a procedure. We can do a one-stage procedure. You can augment the superior rectus transposition in the same procedure, and you can augment the superior rectus transposition, and later, if it is not enough, we can do an inferior rectus transposition as a second stage. So this is the procedure which we currently find very successful, the Nishida's procedure. A small video, I think there is a talk on this procedure per se. So just a quick video. So it's a very minimally invasive kind of procedure. You don't even have to open the limbus completely, conjunctiva. So we use permanent sutures. So there is no splitting, no disinsertion of any of the muscles. So literally anterior segment ischemia is almost negligible chance. And it is even reversible. And it corrects up to 40 to 45 prisms of deviation. So we do a superior rectus and followed by inferior rectus. So this was a child who underwent a bilateral total 6-nerve palsy. That is the pre-op picture in the top and the post-op picture after doing a Nishida's technique. So those were options for total 6-nerve palsy. But many times we have situation where we have a partial 6-nerve paresis. Sometimes if they present in the initial few weeks to less than a month or 6 weeks, Botox injection to the medial rectus is a very good option. So it prevents contracture of the medial rectus and sometimes helps to improve the abduction to negate later surgery. After a while, if there is a good residual lateral rectus function, it can present like an exotropia, where even a good resect of the medial and lateral really is a good procedure. Sometimes, very rarely, when there is almost no residual paresis, you can even do a bilateral medial rectus recession. It just behaves like an acquired acquired esotropia. So in these situations, it's very useful to use adjustable sutures in older patients and adults. So this is a Botox being injected transconjunctivally to the medial rectus muscle in a patient who presented. So before we give Botox, if it's an acute 6-nerve palsy, we have to rule out any cause for a 6-nerve palsy by doing an MRI. So this is an adjustable technique. This is a very standard Dr. S.G. ma'am's video, actually. Very nicely presenting bow tie technique where we cut the knot. So this is being applied to a patient who had a 6-nerve palsy with a good abduction present. So the lateral rectus recession was done under adjustable. So we can do a 1-stage adjustable if it is topical, or after the patient recovers from anesthesia if it's a GA. So this patient did not require adjustment. So the loop is cut and the knot tied. So take home, to manage a 6-nerve palsy remains a continuing challenge. Goals should be realistic, and functional versus cosmetic improvement, we have to assess which is the most needed, and a tailored approach has to be used. Thank you.
I don't know.
Dr. Kavita, Murli, can you take the questions?
Yeah, I have a question, Kavita. How do you manage overcorrections after these transposition procedure? Like you have, let us say, transposed both muscles and you have an overcorrection. So how do you manage?
Actually, I haven't come across overcorrections following, especially a full total 6-nerve palsy. Overcorrections with these procedures seem to be extremely rare. But I think if there is an overcorrection, I would suggest Dr. Rohit Saxena or some more seniors to answer this question.
Thank you. Yeah, I would just say that if you are doing a transposition and you're doing a medial rectus recession along with that, like I generally prefer a superior rectus transposition with a posterior fixation suture and an MR on an adjustable. So that makes the whole procedure adjustable. You are able to adjust for both a little bit of undercorrection and a fair amount of overcorrection. Overcorrections can be handled in 2 ways in this condition. You can advance the medial rectus, or if it's a very severe overcorrection, and it's not that it does not happen, it has happened in transposition procedures because they can be very, very strong. Vertical rectus transpositions can be very strong, especially if you add a posterior fixation suture. Your second option becomes that you can release the posterior fixation suture. So these are 2 ways in which you can handle. Small amount of overcorrections, use the adjustable MR to the advantage. Large amount of overcorrection, especially must do a force duction test. Sometimes the FDT may be tight because of inadequate dissection, and the Foster's is kind of preventing adduction. So release that. Excellent presentation though, Kavita.
How do you choose between SRT and IRT, sir? I mean, both have been proven to be of value in improving abduction. Is there a choice like SRT vis-a-vis IRT?
So I originally, as described by Valles, was that he would do IRTs if there is a hypertropia and SRTs if there is a hypotropia, because according to him, actually, there is an advancement along with the transposition. So according to him, if there's hypotropia, then you do an SRT because the anterior insertion is now more, is lower. Although in our experience, most complications reported with SRT has been a post-op hypotropia in abduction. So I do not actually really follow that. Only condition in which I had actually very limited experience in IRT, and I like doing SRT for a very long time, both in Duan's and in 6-nerve palsy. Only one condition I had actually had to do an IRT. I did an IRT because I had to do an inferior oblique also along with that. So I kind of thought it prudent that might as well use the same incision to, go ahead, do an inferior, because there was a significant V pattern with the 6-nerve palsy. So I had to do a small amount of inferior oblique weakening, and I did an IRT in that. Especially as I find in a couple of cases, I found that in cases where I had done an IO weakening along with an SRT, actually they developed a little bit of hypotropia, because I thought you're essentially weakening both the elevators. So that is why that was the only condition where I actually did the IRT along with the IO. So I would say that I would prefer IRTs where I have an IO weakening procedure to do simultaneously. Otherwise, because of the sheer experience and the less amount of bleeding with SRT, IRT has more bleeding because the inferior rectus is attached to a lot of tissue. The superior rectus, you just need to dissect it from the superior oblique. You just need to be very careful that in your dissection, you don't cut the superior oblique. And that's about adequate amount of dissection. But IR, you need a lot of it, kind of bleeds a lot. The vessels are very, very prominent. So that would be my way of deciding, or I decided that. There may be other experiences.
Anything the other panel members want to add? MS Madam, SG Madam, Dr. Savleen?
I've only to add that talking of reversing the transposition, SRT, yes, even after you cut the posterior fixation suture, sometimes it's very hard to reverse. So it's a very good idea if you are in doubt, not to always have to do an SRT with the medial rectus recession unless it is really tight, and to, as much as possible, use an adjustable suture. Because in my limited experience, once it overcorrects, it's very hard to bring back, is what I feel.
I would like to add one point. Even crossed VRT, partial VRT can be put on adjustable. That's just an additional.
Thank you very much. We shall go on to our next speaker.
One question. If we, so how long can we use the adjustable suture to adjust, sir and ma'am?
I've adjusted up to about a week.
Yeah.
So the first week follow-up, sometimes you're a little hesitant. Actually, if a week follow-up, you have if it comes on the day one, you have to adjust immediately. Sometimes the marked overcorrection comes a week later, and that actually signifies that your medial rectus has probably slipped a little. So that would really require you to explore your medial rectus. So if it is coming a little later week, then you are more concerned that your medial rectus, especially as you may have put it on adjustable, which may have loosened up. If you put it on adjustable, even fixed sutures, medial rectus, if you do a large recession, sometimes it may just recess back a little, and that may be responsible for the late overcorrection that you are getting. Because otherwise you're going to get an early overcorrection if it's an early slip, or if it's because of the transposition procedure, because the superior rectus has essentially taken up function by the very next day. You're not expecting the residual block to really affect the SR function, although we know and in fact, I would always aim for slight under or optimal correction, because we've seen over time transposition procedures actually do better. So you'll see an improvement in the amount of correction over 1 to 3 months. We've seen up to 3 months SRTs showing some amount of at least 10 to 15 prisms of further. So if it's bang on day one, I'm a little concerned that I would have an overcorrection in the along of I asked him to do adduction exercises and hope that the motility remains good and he does not develop an overcorrection, and he may be able to get fusional versions.
Thank you. We shall now go on to our next speaker, Dr. S. Meenakshi. I need to mention the initial because we have two Meenakshis here. And she is going to be talking on Duan's retraction syndrome, my way of optimizing outcomes. I look forward to hearing you, Dr. Meenakshi.
This is Super Meenakshi.
Super Meenakshi.
Thank you so much, Dr. Chitra, for that very kind introduction and for the invitation. So I'm going to start, let me just, so I want to, I have a disclaimer and our disclosure. And the first thing is, of course, there's no financial disclosure, and I have patients' permission to share the photos. And clinicians with more experience in managing DRS are in the audience, who have, are in the panel, I'm sorry, who have also published a lot. And so mine is going to be, approach is going to be with humility and modesty. And it's 6 minutes for DRS is quite a tall order. And let me just also add that ever since I moved from an institutional practice to a private practice, your whole perspective changes. And you start relating to other students that you have trained, fellows who you have trained, who are not in an institution and hence may not be seeing that many DRS over a period of a year or years. And so your approach may need to be tweaked just because of that, fact. So a couple of questions I like to just ask myself is, what brought the patient to you? Was the DRS found incidentally? Did the patient just one day notice that the eye didn't move, or the parent noticed, or they were just kind of looking around and said, oh, you know what, in this case, not only did my eye doesn't move, but I see double. Or rarely they come with neck strain because of, chronic abnormal head posture, or maybe their family or they themselves notice that they're always keeping their head funny in photographs, especially in, group photographs, family photographs. Next is, after you examine the patient, what I do is I list all the things that the patient has. So these are the questions I ask myself. Is there an abnormal head posture? And what is driving the AHP? What is the alignment in forced primary? Ortho, exo, eso. What movement limitation, and of course, if there is any coexisting, vertical. What movement limitation is already present? And what other anomalous activity is going on? So these are questions I sort of ask myself and have an answer to each one of these before you embark on treatment. So 6 minutes, and so I thought I will just share 6 strategies. First, if the face turn is very minimal, if the DRS was discovered incidentally, if there are unreasonable expectations, a difficult to examine patient, like a little kid, then I don't do anything. Wait, masterly inactivity. For example, this kid was noticed to have a very small face turn and was not really, had come in for glasses. And on examination, the optometrist had picked up that the patient indeed had limitation of abduction and a very mild narrowing of the palpebral fissure. So in somebody like this, I would not do anything. Or like this kid, clearly you can see there is some, attempt at a face turn. There is the one eye looks smaller, difficult to examine, did look like possibly DRS, but really what decisions can you make in a little kid who is not cooperative? So don't do anything for now. Second strategy, the abnormal head posture gives the clue as to the greatest anomaly. And so then I try and go after it and try to fix it. And I'll just share with you what I mean by that. So let's look at this young lady. You can see that she has a right face turn. You can also see in this first photograph that her eye is indeed vertically elevated. And now once you start doing her ocular motility, you can see the large overshoot, and then you can see that this is probably what is driving her abnormal head posture. So then look at this gentleman, on the other hand, has got a left face turn. And when you examine him, you realize it's possibly the abduction limitation that he has in the left eye is what is driving the head posture in him. So this lady underwent a Y split of the lateral rectus in the left eye. And I would say that this is much less, but she still continues to have a small vertical. And of course, this needs to be tackled. And that is a whole different topic of, how do you do resurgeries in DRS? How do you tackle residual things in DRS? But the head posture is better. And the patient was happy with the improvement. The third strategy, will my plan make anything worse? This is a question I asked myself. For example, superior rectus transposition may worsen the globe retraction, and this is something to be aware of. So this was one of my very early patients, and I got very excited. And I said, I'm going to do an SRT in her. And so that was her face turn. But you can see even preoperatively, she did have some globe retraction in adduction. So, but I went ahead and did a superior rectus transposition. Head posture was much improved, but her palpebral fissure narrowing continued, and there was definitely globe retraction that continued. In retrospect, did I do the right thing? I'm not very sure. So you win some, you lose some. The fourth strategy. Sometimes I have to make sacrifices and talk to the patient about them preoperatively is a good strategy. For instance, here is a young lady. You can see she has a left face turn and also has some narrowing of the palpebral fissure, but abduction limitation it seems to be the bigger issue and probably driving her head posture. Now, in her, because of the narrowing of the palpebral fissure, decided not to do an SRT, instead did a differential recession of the lateral rectus and medial rectus. Head posture is much improved, but the patient did notice that her abduction continued to remain not very good. And this was despite a preoperative discussion that would be the case, especially because of a large LR recession. Fifth strategy, sometimes I have to operate on the other eye, and this again needs some counseling. And this is particularly, this was, I think, a pre-SRT days patient. The one that I showed you earlier had a had a left face turn and possibly driven by the abduction limitation in the left eye. And here he underwent an asymmetric bimedial recession, as described a long time ago, a larger recession of the right eye and a smaller one of the affected eye. With a good correction of the head posture. Of course, the exotropia in primary was also not very large. And so I was a little reluctant to do transposition procedures in him. And so he ended up having surgery also on the other eye. The sixth strategy is I make sure I inspect the patient from head to toe, looking for any systemic association, like you can see in this little kid. You can see that she has probably mostly ortho DRS, but has abduction limitation in both eyes. And but you can see that she has a clipple fail anomaly. It's not that her dress is riding up her neck. She does have almost no neck because she has a fusion of the vertebra. And this is something that you have to pay attention to because she may need a nasal intubation if ever you decide that she needs surgery. Seventh, I said sixth. There are still many things that we have not discussed. The more and more awareness about DRS and coexisting bands. I have very limited experience in VRT, periosteal fixation, IRT, and DRS. And as I already said, there are many others who are in the panel who have more experience than me, and I would look forward to their take on these. But these are my approaches to a patient of DRS. And thank you so much, Dr. Chitra, once again.
I'll ask a very basic question before Murli and Rohit and all take on. Would you believe in doing a systemic evaluation for your DRS patients?
Yes and no. All pediatric patients, when they are going to need surgery, especially complex strabismus, I usually try and get a pediatric evaluation. DRS especially is known to have a lot of syndromes associated with it. And so, yes, I think the answer is yes.
Yes. Dr. Murli?
I had two questions. One is there a limit to how much you can recess the normal eye medial rectus? I mean, is there some kind of a limit? Like some people say you shouldn't recess beyond 4.5 millimeter. And second is, of course, like to the panel members, when would you do a lateral rectus periosteal fixation? How much of exotropia? Is the amount of exotropia a criterion to decide on periosteal fixation? Or?
I will answer the first question and let perhaps Rohit take the other one. So as far as medial rectus recession, I have always done a little more in the normal eye than the left eye, with the idea of fixation duress that would perhaps improve the abduction in the left eye. It doesn't really improve that much, but yeah, perhaps it improves a little bit is what has been the original thinking. The problem always with recessing medial too much is, I think it's in other situations a setup for consecutive exo. It also may be a setup for developing convergence issues. All these may be lesser consideration in a DRS patient, but in other, generally speaking, yes, I would not recess medial rectus more than 5-6 millimeters would be the limit. Rohit, would you like to add to this?
So I think the limits are for the involved IDS. So I would rarely go, beyond 5. In fact, 4.5 would be a more comfortable number for me. Of course, the final thing is decided based on the post-duction test. So you, irrespective of the amount of recession that you have planned, post-surgery, your FDT should be free, which usually is by 4.5 or 5 millimeters. I have never gone beyond that, because the more you recess, the more you risk adduction deficits. So that's something which you are going to create. Even if you recess small amounts, 3 or 4 millimeters, you're going to have some amount of adduction deficit. So going beyond that, you have significant adduction deficits. So that's why I would never. The other eye, as Dr. Meenakshi said, there are really no limits. It's like, theoretically, I would say I would do as much as I would do in a standard comitant esotropia. So 6 to 7, depending upon people's ease and all, is amount I would do. People have described much larger, and as Dr. Meenakshi says, it's based on the fixation duress concept, but it does not somehow, it has not found to be very, very beneficial. So I have actually not, I would always prefer an SRT if I could to a bimedial recession. But yeah, as Dr. Meenakshi pointed out, sometimes you can have a child with significant retraction where, SRTs may not be such a good idea. Only do it with, to answer your second question, with periosteal fixation and then do an SRT. So in ESO Duans, that would be my indication, very rarely though, of doing a periosteal fixation of the lateral rectus when I'm planning an SRT in the presence of a severe co-contraction. Otherwise, for exoduans, more than the angle of deviation, I'm more concerned about the abduction that the patient has preoperatively. So if there is a fair amount of abduction, I know that this patient has, some amount of normal LR function, and I don't want to lose that, because obviously abduction is going to be something the patient is going to remember you always for the loss of the abduction. So I would do very large LR recessions if required, a Y split, but not a periosteal fixation. But yeah, if there is hardly any lateral rectus function, or it's a very large exo that you can hardly make out any LR function or any abduction, then I would say that would be, or very, very strong vertical, which Dr. Meenakshi showed, that one patient where the eye almost disappears up. So that would be a good patient to think in terms of doing a periosteal fixation. A third of these patients in which you do only periosteal fixations risk going into an esotropia. We had done a thesis, Dr. Pradeep Sharma, and we had coalesced a lot of paper data. Unfortunately, we couldn't publish because the resident left. But we found that a third of these patients, actually, we had to go back and do some procedure to correct the consecutive ESO. So a small overcorrection, a medial rectus recession, a large overcorrection, an SRT. So as the second surgery for periosteal fixation. But primarily to answer, if there is very severe co-contraction and very little LR function, I would think of periosteal fixation.
Thank you. I'm going on to the next talk, because I think a lot of discussion has happened here, and we have with us Dr. Jitendra Jethani, who is the director of the Baroda Children Eye Care and Squint Clinic, and he's going to be talking on modified Nishida's procedure and its applications.
Thank you so much. Good evening, everybody. Thank you so much for the opportunity. And I would be speaking, I just have 8 slides because the time is 6 minutes. So we would just begin with what exactly is Nishida's procedure. So this was described in 2003 in Japanese Journal of Ophthalmology. And basically, the author themselves claimed that this particular procedure was better than the normal transposition procedure because of the obvious advantages that there was no cutting and no splitting and without any tenotomy of vertical recti. So basically, it is a procedure, muscle transposition procedure, in which you basically shift the halves of vertical rectus and suture them onto the sclera, like 8 millimeters from the insertion of lateral rectus. So this was the first article. They had multiple. They had follow-up article. This is the actual surgical technique, and this is okay. So this is the diagram which sort of sums it up. Basically, it is the superior rectus and inferior rectus, and Nishida described it for abducens palsy, and they presented their data, and they tried to show that this was a good procedure. There was some abduction which did generate at the end of the surgery, but otherwise it could correct up to, in their study, it could correct up to 35 present diopters with medial rectus recession. I was listening to the previous talks, and this is one of the surgeries in which we are doing a modified Nishida, where we are doing adjustable medial rectus. It's a very good idea to put medial rectus on adjustable, especially with transposition procedures, mainly because of the fear that you may end up into overcorrecting, or even if there is some undercorrection, you can still tackle it. But mainly it is for the fear of overcorrection. So here we are hooking the superior rectus muscle, and we will put a suture 8 millimeters posterior to the insertion, and then this will be a non-absorbable suture, and this would be to avoid the blood vessels and avoid any clamping the blood supply of that particular part. And next, this particular thing will be sutured 8 millimeters from this particular incision, so that will be around 16 millimeters from the actual limbus. We would be suturing this particular proline. Yeah, you are taking around 8 plus 8, 16 millimeters. And similar procedure would be done on the inferior rectus. Once you pass the suture here near to the equator, you tie another suture here. So this is how we are passing the 6-0 proline. Now this is a non-absorbable suture, and similarly we would handle, this is superior rectus, and similarly we will handle the inferior rectus also. From the temporal half of the inferior rectus, we will be transposing it. We will be suturing it right between the inferior rectus and the lateral rectus, and that would generate the abduction force post surgery. So that is the whole idea, and so this is how a similar anchoring we are doing towards the lateral rectus. We are shifting the abduction force. We are taking the vertical rectus, and we are taking their force to generate abduction in this particular surgery. Now any surgery has to be compared with the actual procedures. We have to compare its efficacy and comparison. We presented this data in I think 2019 in AIOS, where we compared Nishida's procedure with partial VRT in abducens palsy, and we found that the improvement in primary position angle was comparable in both the groups with medial rectus recession, but the mean improvement in abduction was more for the partial VRT and as compared to Nishida's procedure. The advantages are obvious. It's surgically more simple. It is less traumatic to the muscles. A tenotomy and splitting of muscles is really not required. And therefore, the theoretical chances of anterior segment ischemia are pretty low with this particular procedure. The indications, it was originally described by Nishida for lateral rectus palsy, and then there are multiple indications where so basically any transposition procedure we have tried to do Nishida or modified Nishida for all those incompetency or for monocular elevation deficit, medial rectus lost muscles aplasia, inferior rectus aplasia, and lateral rectus paresis is already the indication for which it was originally described. Now we now have modifications of modified Nishida. So we have adjustable Nishida. We have authors in the panel and full tendon shift. Now, you can take a full belly and shift it. I'm not able to place that paper, but it was I think by Dr. Pradeep Sharma, probably, where they tried to shift the full tendon for medial rectus aplasia. So that is summing up the modified Nishida procedure and indications and the surgical procedure. Thank you so much.
Murli?
Yeah, I have a few questions for the panel members. After all these transposition procedures, should you choose to give Botox to the medial rectus, do you find that there is some loss of efficacy at 4 months when the Botox effect wears off? I mean, to the panel members, of course, Dr. Jitendra also, that if you do give Botox to the medial.
Yeah, there's a wonderful article when I was searching for the data on Nishida. There's a good article where they have compared pure Nishida versus Nishida with medial rectus recession versus Nishida, medial rectus recession, and Botox in medial rectus. So they found that Botox does increase the efficacy by almost 15 to 20 prisms in immediate post-op. And obviously the efficacy will lose over a period of time because the medial rectus function will kick in after the effect of Botox is gone. But I don't have any personal experience, honestly. I'm very low on Botox. Yeah.
Okay. Any other panel members on Botox? MS Madam, SG Madam, Dr. Savleen, Rohit sir?
Not, I mean, N is equal to 1. So I don't have enough experience to say one way or the other. I'm just thinking aloud that if the transposition effect improves with time, which includes possibly Nishida, it was more for other transpositions, but then hopefully that will be balanced out by the Botox effect wearing off over time. That's all I can say.
I don't think that much amount of transposition, I mean, that much amount of difference it will make. I mean, medial rectus is unopposed here. So, I mean, we cannot expect a huge, 20-25 prism diopter. But yes, obviously, over a period of time, transpositions do give better result. Like we have good publications from Arvind, where they have shown that in MED, over a period of time, the eyeball shifts up. Maybe inferior rectus becomes weak because inferior rectus goes down, and but transposition procedures over a period of time do give augmented results, but not as much as we would be giving Botox, because it would be completely paralyzing the medial rectus.
So no experience in doing transposition procedures with Botox, but one would believe that the reorganization would assist. Botox would help that, so you may get good response initially, which may remain sustained. So you expect that there is a little bit of reorganization of the muscles and the tissue planes, which increases the effect of the transposition. So probably, and people who have done Botox with transposition procedures, I just remember 2 cases. Of course, they were not pure simple VRTs and a 6th nerve or thing like that. They were complicated strabismus. So difficult to again give experience of Botox along with that, but definitely the result is augmented and is much better, and probably is reported to be more sustained. But again, just a caveat on the important to remember that when we are talking about Nishida and thinking that it's absolutely does not compromise vasculature, please remember that when you're tying the knot, if your vessel is within that knot, it's actually acting like a ligature, and it may actually significantly compromise at least blood flow from that vessel. So if you are lucky and you're able to spare one of the both the vessels, if you're doing vertical transpositions or lateral rectus, if you're doing lateral rectus, definitely make sure that you miss out on that vessel. But if you're doing vertical recti, just try if possible to either dissect out one vessel and pass your sutures underneath it, so that there is less of that tourniquet effect of the suture that you're passing. Otherwise, I would say some amount of vascular compromise does occur. Unfortunately, we don't have good ways of measuring it at the moment. Dr. Savleen, our tech savvy in Strabismus, maybe, or Amar, they may help us how to measure vasculature supply to the anterior segment with our vessels. But please remember, when you're doing multiple muscles, sometimes we get a little excited when you do 2 muscles and think that, we could do a transposition, Nishida, which would be, not compromise vasculature. Remember, it may. You need to be just careful.
The biggest advantage is, I think I have done 2 or 3 cases, as I've done a 4 recti surgery for all these large angle esotropia following 6 nerve palsy. So you did a MRI session with a Nishida with an LR plication. So, I mean, they really did well. But yes, I mean, no doubt, we haven't seen the anterior segment vasculature, how much is the compromise. And I think some work is going on in our department as well. I think Dr. Shweta is doing it, following on the angiography and all. So probably you might have some comments.
I have I have experience with full tendon transfer in modified Nishida, and I have done a lot of cases, and they are giving actually good correction without any evidence of anterior segment ischemia. Like in MED, they are giving correction of around 50-55. In 6 nerve palsy, they are giving lesser correction around 40-45. So they are even I have done in ExoDRS post LR periosteal fixation, and they are giving good correction. The correction is little lesser in restrictive squint. I have presented this paper in SAO, so soon we'll be publishing this paper.
Thank you. Dr. Ramesh has yet to join. Dr. Pradeep has not joined, no?
No, madam, I don't see him. Should I call him?
Yeah, so then we shall go on to Dr. Rohit, and the next speakers, they may have joined by then. We have with us Dr. Rohit, who's a not just a professor of ophthalmology, but is also our very dear member ARC North, and he's going to take us further forward on his topic, nasal split transposition of lateral rectus muscle for complete third nerve palsy. On to you, Dr. Rohit.
So thank you very much, Dr. Chitra. I'm audible?
Yes.
Great. So I'll essentially run through quickly the nasal transposition procedures, the nasal split transposition of lateral rectus, as it is now called, with a lot of data now available world over. Originally described by Taylor and Kaufman, where they talked about, Taylor talked about the complete transposition, and Kaufman in 91 talked about the Y split. So a lot of time ago it has been described, but we kind of all got interested with the work from Gokigit and of course our dear friend Jaspreet, who actually published papers. This was Gokigit's paper in which she has demonstrated that the lateral rectus superior half goes from underneath the superior rectus superior oblique onto the medial side, and the inferior half goes from underneath the inferior rectus inferior oblique onto the medial side. This is the medial rectus, and this is where it is sutured. Both had shown that the effect was less than desired, and there was some amount of residual deviation still left. So we kind of modified it and actually talked about the same procedure, same things, the superior half from underneath the superior rectus superior oblique and being sutured, but along with the transposition to the medial side, a posterior fixation suture superiorly and inferiorly in the same way it was passed from underneath the superior rectus superior oblique and inferior rectus inferior oblique. So this is some of the cases of the non-adjustable variety which we had done. Very good correction, as you can see. Of course, there is a little bit of lack of control as you would find in an adjustable procedure. Shah et al. Had talked about an adjustable procedure where they put it on adjustable on the same side of the medial recti. So the superior half brought superiorly, inferior half brought inferiorly, while it allowed us a little bit of recession to correct for over corrections. You couldn't actually manage under corrections. So we modified that. This again, the same thing, but we modified and sutured it in a cross-action manner. So you didn't have to tie it all the way to the opposite pole. So the inferior split end was sutured superiorly, superior edge split end sutured inferiorly in a cross action on an adjustable. So intra-op adjustment, of course, you try and place it as perfect as you want, and then both for vertical and horizontal. And of course, this gives us an advantage that you could adjust for both horizontal, of course, and a small amount of vertical. So I'll just run through the video that is there for the LR transposition. This is just making sure that the FDT is free. It's very important that the FDT should be nearly free, because otherwise you're going to land up in trouble when you're transposing the halves onto the nasal side. I use a fornix for this. So 4 fornix incisions are made. This is the first one on the inferotemporal quadrant where you hook the lateral rectus. So we hook the lateral rectus, and I would always go do the inferior oblique before I do anything on the lateral rectus, because it is very convenient to just prolapse out the inferior oblique. Here, I don't have to do any surgery on the inferior oblique, but I will open the posterior intermuscular septum so that I can pass the, this is a traction suture that I'm placing, and so that underneath this, I'll be able to pass my inferior slip of the lateral rectus. So this is the lateral rectus that has been hooked now. I will be dividing it into 2 halves. So a 5 mm split, assuming that the insertion is about 10 millimeters, a 5 mm split of both the halves, which are of course sutured just like you would be suturing any recession muscle. So 1 double-armed or 2 single-armed at both the upper and the lower ends. So this is the passage of the sutures at the lower end. Just a 6-ovical suture, disinserted. So this is the inferior half that has been disinserted. The superior half is similarly sutured and disinserted. So we have now both the 2 halves that are available for the transposition procedure. So the 2 halves are now free. The inferior half is now passed from underneath the opening we had made in the posterior intermuscular septum of the inferior oblique. So you clean up the posterior intermuscular septum and you pass it from there. So here we are making the second opening. This is the superior oblique. So we are tackling the superior oblique. Now we're going to pass the superior from underneath. So you can see the superior oblique. I'm doing a posterior tenectomy of the superior oblique along with this. So this helps in 2 ways. It helps to mobilize easily. The posterior fibers are not there. And of course, the abducting force of the superior oblique is not there. And again, from underneath these anterior fibers, I bring out the superior slip. So now we approach the nasal end. So 2 fornix incisions, of course, will be made. So we take a central traction suture. We make the fornix incision, and the muscle is passed from underneath the inferior rectus and brought out adjacent to the medial rectus. Similarly, superior end, and the muscle is brought out, the sutures are brought out from underneath the superior rectus. Both of them are now pulled. So you can see now the muscle is coming close to the medial rectus. And they are, of course, this I'm showing the cross action, the adjustable procedure. So you can see the inferior sutures are now being brought superiorly, and the superior sutures are being brought inferiorly in this cross action manner, and they are going to be sutured here. So you can see this. I don't have to pull it all the way to the insertion of the medial rectus because I want to have some amount of adjustable part left, and I'm going to adjust that intraoperatively when I'm going to move the short tag noose. So these I place on the short tag noose adjustable. So you have a pole suture and you have an adjustable suture. A traction suture is placed to pull the eye into a bit of adduction. And this is the tying of the short tag noose that is there. This is the pole suture that is being tied. And we are going to loops on the pole suture. And just below that, we are going to tie our, this is the, you can see the noose that is being tied so that you can do a short tag noose. Advantage is that I'll close all of this, and if I don't require any adjustment, which fortunately we have not had requirements very frequently, we're just going to level it. So this is the short tag noose, we suture and we close. So this is how we're going to close all the 4 fornix incisions. So show you adjustable results. This is again a third nerve palsy. You can see post-op, little bit of vertical that was there got corrected, and with the 2 separate adjustments that we could do. Again, in this case, there was a little bit of vertical hypertropia that got corrected with the adjustment. And just to complete for CCDDs, in fact, Dr. Pradeep Sharma was the one who said that this would be the best intervention, our LR to MR. And you can see this because the when the eyes are on gazing right, you can see there is a synergistic divergence. So in cases of synergistic divergence is probably the most optimal surgery. So the lateral rectus, which contracts on attempted adduction of this eye, actually is used when you do the LR to MR transpositions. You can see good primary gaze alignment. You can see some amount of adduction. Unfortunately, you lose out on the abduction that was there, but usually they are highly exotropic, so they don't actually miss that. And there is good amount of convergence also. So this is ideal situation, LR to MR, ideally placed for a synergistic divergence. So nasal transposition can achieve excellent results. Adjustable modification can allow optimization of horizontal and vertical alignment, and cross-section provides us the ability to advance in undercorrection along with recession. Thank you very much for the opportunity.
Thank you very much, Rohit. Amazing talk. And Murli, you need to take the questions.
I have a question for Dr. Rohit sir and other panel members. Should you have an undercorrection after this procedure, LR to MR transposition? What are your options?
If you've done a fixed surgery, you can do an MR plication. You've just operated on one muscle. So no problem there. In fact, the initial ones which we had tried without the posterior fixation suture, where there was a residual exo, and in cases where we did the full transposition, where there was significant vertical also, there we had gone in back and done a medial rectus plication. Good results with that, especially because now you don't have, the lateral rectus, unopposed action. So the problems of a poor medial rectus function is not there. You actually have some kind of tonus on the medial side because of the LR to MR transposition. So the second surgery of medial rectus plication gives you very good results. And the other, of course, if you do an adjustable, you can of course advance it like we've shown. So like we do the cross action, we have been able to advance it. Like I said, we've generally done it intra-op adjustments, but in one or two cases only we've had to actually go back and adjust it, but more often for a little overcorrection than for undercorrection, because we invariably leave it slightly overcorrected intraoperatively and allow for a little drift to happen. So when in two cases it didn't actually happen, we went back to weaken it.
I think that was the initial incentive probably. I think Rohit, you were talking about. We had undercorrection in our patients because we were not using posterior fixation. We were getting about 60 prism diopters for a 90. So we had to do those large MR resections for those things. And probably that is the time they came up with a good idea of a posterior fixation sutures, which are now no doubt working quite well for such large deviations.
The original procedure described by Gokijit was not the splitting. Actually, she transposed the whole of MR under the inferior rectus. So any experience with that? I mean, how does splitting, does it distribute the force evenly?
So we actually, I'm surprised because Gokijit, this publication, which actually we referred to and got our idea through, actually talks about the split. Although I'm not sure she does transposes the split ends from underneath the obliques also. I think she just does it from underneath the recti and not the obliques, but I prefer the obliques because it provides a lot of mobilization. Going over the obliques, actually, it kind of wraps around the obliques and therefore it is a little difficult to mobilize it. Yeah, but to talk about full muscle transposition from a side, we did that, in fact, in large verticals along with the horizontal. So that is a case where I was talking about you would get some amount of undercorrection for the exotropia. So for a hypotropia, we transpose the entire lateral rectus from underneath the superior rectus superior oblique, from the superior root to the medial rectus. And for hypertropias, from the inferior oblique inferior rectus onto the medial side. This provided us a lot of vertical correction, but the horizontal was not as great. So in these cases, actually, we had to go back in to do a medial rectus plication.
Okay, thank you. Now I think Dr. Pradeep has not joined and Dr.
Ramesh is here.
Dr. Ramesh has joined. Yes.
Yes.
Dr. Ramesh, we can take your talk now, and I think it is most appropriate that we take his talk because this is the National Myopia Control Week, if I'm right. And Dr. Ramesh is going to be talking on of course, I introduce him. He heads the Department of Pediatric Ophthalmology Strabismus and Neuro-Ophthalmology from L.V. Prasad Institute based at Hyderabad. And he is going to talk on my stepladder approach to minimizing and managing myopia progression. On to you, Dr. Ramesh.
Thank you, Dr. Chitra. Thank you, ARC, for this opportunity. I hope I'm audible, right?
Yes.
Okay. So quickly, I'll talk about myopia progression, and I'm going to give a recipe. It's like we heard a lot of strabismus. This is something, it's a common refractive error. It's on the rise. You can see, if you look at the prevalence, it's going up. And by 2050, maybe 50% of the population of the world will have some kind of myopia. This is what is predicted. It's like, it's one of the pandemic. And if you see, India, it's going to be around 40%. Obviously, if you see East Asians, it's close to 90%, most of the places. And it's catching up. It's catching up in Africa. It's catching up in US. It's catching up in South America. So it's everywhere. We need to look at two things. Can we prevent the progression? That's number one. And the second thing is, can you kind of prevent myopia? Both the things should go hand in hand. So if you look at this cartoon here, there are so many myopias. You can see in the first one, that's about blue. Who are the progressors? It's not all of them. We need to catch these progressors. And also we should understand that some of this, not all of them, will go into that red zone called high myopia or pathological myopia. At each step, can we do something at this point of time, looking at the predictability model, whether in the pre-myopia stage, can we do something? Whether once they progress, can we do something so that high myopia or pathological myopia, which has a very, very high chance of other complications, can we prevent? What do? We always ask family history, lifestyle, sports versus academics, private school or government school, homework, parental concerns, do cycloplegic retraction in every patient. And then we have three sets of category of patients: hypermetropes, pre-myopes, and myopes. What do? Just observe if they are hypermetropes. Outdoor activities, it's one of the very important strategy which can work in hypermetropia and pre-myopia. Once they set in myopia, then the role of screen time, outdoor activities is not so much. I would not say it's never there, but if at all you can make a difference, we should catch hold of this pre-myopia or hypermetropia patients early in their life. So if the myopia is the definition, if you see the International Myopia Institute definition, anything less than 0.5 is myopia. If they are stable, for example, less than 0.5 diopters per year, they are stable. If they progress more than 0.5 diopters per year, we call them as progressors. Axial length has to be monitored in each visit. What do? We take a comprehensive approach. It's not like one thing you do and then look at what works best for the patient. We look at axial length, we look at peripheral refraction, we can do OCT imaging, you can do many of the other research stuff as well if you want to do, but there are some basic things before we consider. This is what, in a snapshot, what can be done to prevent the progression or slow down the progression of myopia. Number one, lifestyle modification, as I said. There are pharmacological options, there are optical corrections, there are special spectacles, there are special contact lenses, including ortho-K lenses. Let's look at 4 or 5 options, what we have in this rest of the 4 minutes. As you all know, pharmacological therapy has become very, very common in the last few, I would say 3 to 4 years. 1%, 0.5%, 0.1%, 0.01%. If you look at, they all are effective, but higher the dose, it's more effective. But if you stop the eye drops after 1 year of discontinuation, the rebound phenomenon is more with higher percentage. And all of us don't want to use 1% because it has effect on dilatation, accommodation, and everything. What we use generally is 0.01%, what you can see in the last slide. Reduces the myopia progression. It's the rebound phenomenon, it's very less. More and more data is there that 0.05% is much better than 0.01%. So the world is going more towards 0.05% if you talk in November 2022. That's where it's going, but still there is a proportion of patients we are still getting 0.01% compared to 0.05%. What are the things to consider before starting low-dose atropine? All of us know cycloplegic refraction, considering spherical equivalent refractive error, categorizing them into pre-myopes, myopes, hypermetropes, and parental myopia history and their counseling. Because nowadays, the myopia counseling takes more than strabismus surgery counseling. That's what is happening in 2022. And then you need to follow them up very, very regularly. So if they are progressing every 6 monthly, if you check, start them on 0.01%. It's debatable, either OD or BD. There are some subset of patients we might have to increase. And also you can look at other alternatives. Look at this slide. We are looking at atropine 0.01%. Other alternative, I'll come in a minute. If they are stable, less than 0.5, probably you can stop after 1 year, depending upon the age of the patient and also response. If it is stable, probably at this stage, you can consider discontinuing. This is the earliest, in my experience, other panelist opinion here. If they progress, we might have to restart. And if they are progressing more than 0.5, you have to continue either BD dosage, reconsider the dosage, or add alternative. What are the alternatives? We have DIMS, the special defocus lenses, or Hall study. Both of them, look at this simple table. There is DIMS 79 patients, single vision 81 patients. And also you can see what is their effect on the refractive progression and the axial length progression. The table is self-explanatory, how effective these two lenses are. You can see both at 6 months and at 12 months. And in my personal view, take a step ladder approach. Start with naturopathy. More light, sunlight, less screen time. Go out and play. During our childhood, our parents used to call them from outdoor to indoor. Now it's a situation, everybody has to be sent outdoor because all of them are glued to indoors. Second option is start atropine. Dose and frequency we can discuss. And the other thing is alternatives like optical or contact lenses. This is the final slide, which tells everything. Whenever there is a myopia progression, check axial length, check accommodative lag, check family history, do open autorefractometer. Then, depending upon that, advise lifestyle changes like no or less screen time, open outdoor activities. These are simplest thing anybody could do. Obviously, full correction of myopia. Think about atropine drops. If there is accommodative lag, think about bifocal glasses or progressive additional. If there is peripheral hyperopic defocus, consider DIMS lens or halt lens. If none of them are there, the child is older enough where you want to
time is up.
control. I'm just done in just 30 seconds. If there is ortho K, you can give, and sunlight is very, very important. Very rarely you have a combination therapy of DIMS or ortho K. The effectivity of it is still we don't know. That's all I have to share. Myopia mantra is master, measure, monitor, and manage. Thank you so much. If you want to hear more about this, we have a webinar on Saturday and Sunday. Thank you so much.
Thank you very much, Dr. Ramesh. That was a very interesting talk. It actually interested me more than all the other talks today. So relevant to all of us. And I have a question before more complex questions. Do you take the peripheral refraction into account when you give DIMS classes?
Absolutely. We do peripheral refraction in every patient. That's one of the decision makers for us. You know, if it is pure axial, we tend to give more of a pharmacological refraction. If it is significant, itself may not work. That's why we select this patient into more of that.
We missed your last sentence. There was network issue.
Yeah, if it is peripheral defocus, we consider these kind of special lenses as a primary modality of treatment.
Murli?
Yeah, I have 2 or 3 questions. One is, how do you do a peripheral refraction? I know the time is too short. And second is the original study on DIMS lenses. I don't think they did peripheral refraction to prove that there was a hyperopic defocus. If there is they did not measure accommodative lag either, and as you rightly pointed out, the sample size was just too small. Neither did the ATOM study measure the accommodative lag. So, I mean, I understand if the accommodative lag is a little more, would you advise against low concentration atropine, or and how do you do a peripheral refraction? And that these studies really did not study these factors. So, I mean,
that's what exactly we are trying to customize myopia progression treatment, Murli. This is the way we do open refractometer. This is you can see the patient is looking to the right, nasal and temporal, and we can look at what is the peripheral relative hypermetropia. So whatever the problem the particular patient has, it's not that all of them have peripheral defocus. Let me say that it's never 100%. But unless we check, we will not know. What our attempt is to make this treatment customization. Otherwise, what happens is there are 16 to 18 parameters are there. Options are there for an individual. Where to put what? Rather than putting everything together, we are trying to customize. Okay, if this is there, let's give this. It's not that we have an answer completely. Okay, this is what. Unless we start looking at that, we will have a mixture of everything. I just wanted to share this picture. How do you do the peripheral refraction? In another 2 days, we are coming up with the innovative tool so that everybody anywhere without this instrument can do a peripheral refraction. So that more and more people in their own clinic, even if it is a private practice, they can do it. That's what will come. In another 2 days, we will release that. So that will be good because we wanted to, because this is a hard thing. Who wants to buy a 25 lakhs instrument for just to do an open refractometer? Institute, it's possible because there are grants, other things. So that's one of the things we are working on.
Anything else, Dr. Murli? Do we go on to the next speaker?
Yes, ma'am.
Thank you. Thank you so much.
Thank you very much, Dr. Ramesh. We shall now go on to our next speaker. Is Dr. Akhila there with us?
Yes, ma'am.
Okay. She's again a senior consultant from Shankar Nethralaya, Chennai, in pediatric and neuro ophthalmology, and she's going to be talking on recognizing and managing the long-term complications of pediatric cataract surgery. On to you, Dr. Akhila.
Thank you, ma'am. It's a vast topic. I would try my best to cover it as short as possible. So as Dr. Ellis has rightly told, that young children with intraocular lenses are a unique clinical responsibility of every pediatric ophthalmologist and may need a long-term follow-up. And these are some of the most common postoperative complications that as pediatric cataract surgeons come across. Apart from correcting the refractive error and the amblyopia, we do have certain conditions which necessitate a secondary intervention in these children. Most common being the visual axis opacification and as well as glaucoma and strabismus. The other less common complications include a retinal detachment, a membrane formation or a pupillary capture, and IOL deposits and decentration of these intraocular lenses. And of late, we do see IOL opacifications as well in certain children. So how do we manage the residual refractive error, which is very common in all patients who are being followed up for following cataract surgery? In preschool children, we give them single vision glasses with appropriate intermediate near vision aid. Whereas when these children go on to enter school, then we give them bifocals or even progressive lenses can be considered in these children. And as they become young adults, then they might end up with a large myopic shift, in which case you might have to consider either contact lenses or of late even refractive surgeries and IOL exchanges have become common in these group of children. Now, how do we rehabilitate aphakic children? The gold standard would be, in case of bilateral aphakia, it would be aphakic glasses. These are easy to manage both for the child as well as for the parents, but of course it comes with a induced magnification and chromatic and spherical aberrations and as well as ring scotomas, which needs to be taken into account. And if in case there is an option of switching over to contact lenses, even in bilateral aphakics, you can consider contact lenses. And of course, the standard management protocol in unilateral aphakics would be contact lenses. And as the child becomes ready for a secondary intraocular implantation, unless otherwise there is a contraindication, you can consider a secondary IOL implantation once a child enters the school-going age group around 3 to 4 years. Now, this again is one of the most common complication or rather challenges which you face when you're managing children who are followed up for cataract surgery, that is amblyopia. Since there is always a reason for a delayed presentation and delayed intervention, associated strabismus and nystagmus, and the asymmetry of the cataract, all these things do contribute to the development of amblyopia. And always set realistic goals when you're approaching these children and talk to the parents before you take them up for surgery. Explain the visual prognosis and the need for constant glasses and patching, whatever is required appropriately. And patching can be either part-time or you might have to consider even aggressive patching to improve the best possible vision. Now, as the infant aphakia treatment study came up with visual axis opacification as the most common indication for secondary intervention in children who've been treated with lensectomy. And this incidence is almost 100% in children if the posterior capsule is not managed appropriately on table and can completely undo the benefits of a cataract surgery in no time. So primary posterior capsular excess is usually recommended in all children who are lesser than 6 years of age. And this can be extended in certain children where you have children with intellectual disability, children with uveitic cataract or post-traumatic cataract, where the incidence of PC opacification is going to be more common. So you can extend it even up to 12 to 14 years of age. And even in children with nystagmus, if it is possible, you can extend the age limit for doing a posterior capsular excess. Now, even in a normal uneventful cataract surgery, you can still have a visual axis opacification. But the other more predisposing factors include the smaller capsulotomy size, the lesser age at surgery, a sulcus versus a back fixated intraocular lens, and as well as the type of the cataract. In case if it is associated with other systemic conditions, the incidence of visual axis opacification is going to be relatively more higher. Now, how do you manage a visual axis opacification? If it's a child who can cooperate for a YAG capsulotomy, then it can be ideally done under topical anesthesia. And very rarely, you might have to consider even YAG capsulotomy under general anesthesia. Always remember that these capsules are relatively more difficult, unlike in an adult. And you might have to talk to the patients that they might need a repeated YAG capsulotomy if it is going to close with time. And always take care of lens fitting. And in case if all this procedure fails, then you might still have to consider a membranectomy. So in children who are younger, who do not cooperate for a YAG capsulotomy, then you have no choice but to plan a membranectomy. And this is more common in pseudofix as compared to children who have undergone lensectomy. And the approach can be either an anterior limbal approach if the lens is in the sulcus, or if the lens is in the back, then you might have to still plan a membranectomy through the fast plan approach. This is just a short video. I don't know if I have time to run the video. Next most common or the dreaded complication of any pediatric cataract surgeon is the aphakic or the pseudophakic glaucoma. And this incidence is pretty large because it's like around 15 to even up to 45%. And usually these children do not have any presenting complaints. So always have a constant vigil as whenever the patient comes to you for a postoperative visit, if there is a unexpected or an unexplained myopic shift or a relative corneal haze, a slight variation in the corneal diameter, or a suspicious disc, or a borderline intraocular pressure, subject the child to an examination under anesthesia to rule out a glaucoma. Unless otherwise you have a contraindication, always check intraocular pressure in all children who come for a postoperative follow-up. And I do not want to overemphasize the need for a gonioscopy before you plan a cataract surgery.
The time is up.
The risk factors, the single common risk factor for developing aphakic and pseudophakic glaucoma, as we all know, is the early age at intervention. Age of less than 6 weeks of age is associated with a very high incidence of postoperative glaucoma. This is a study which was done in our own institute, where they again came up with the age lesser than 3 months to have the highest incidence of glaucoma. Now, again, the medical management followed by surgical management is your line of treatment for secondary glaucoma in these children. Now, again, coming to strabismus, strabismus is almost a part and parcel of your pediatric cataract, because there is always a disruption in the binocular sensory as well as the motor fusion mechanism, and it might be even as high as 86%. And because of the unilateral cataract and asymmetry in the density of the cataract and underlying amblyopia, strabismus is very commonly associated, and it might add to the visual impairment what the child already has. So again, management of strabismus in these children is you usually consider in some children there might be a spontaneous improvement of the strabismus, and you might have to plan an early intervention if the visual outcome is going to be good. Otherwise, you usually delay it in children with amblyopia. You treat them with patching. You just strive for the best possible vision and then plan your surgery when the angle becomes stable and reliable. Now, these are some of the pearls when you're planning a strabismus surgery. You take the large refractive error into account and you change or modify your tables accordingly. If it's an aphakic child, try to measure it over the contact lenses. And if the child has an associated nystagmus or an AHP, that needs to be factored in your surgical plan. Do a careful dissection and always prefer a fornix incision, because you do not want to scar the conjunctiva, because these children might require secondary procedures in future. And always talk about resurgeries in these children, which is always a high possibility. Now, coming to retinal detachment, this is relatively lesser, and doing a posterior capsulotomy or an anterior vitrectomy does not necessarily increase the risk of retinal detachment in these children. But of course, myopia and intellectual disability are some of the factors that increase the risk of retinal detachment in these children. And fundus examination and all postoperative visit is mandatory. And if there is an access to optos, always document the peripheral fundus, which may not be possible otherwise in children because they may not be too cooperative. Now, this again was a study which was done in our hospital. And this again came up with the fact that the males, myopes, and children with intellectual disability had a higher incidence of retinal detachment. Now, coming to decentration of the intraocular lenses, these are more common in sulcus fixated lenses and traumatic zonular loss and inadequate capsular support and asymmetric placement of the intraocular lenses. If one of the haptic is in the sulcus and the other one is in the back, then there is a high chance of decentration of the intraocular lenses. So you try to reposition the lens and try to redial it if it is possible. Otherwise, you might have to do a refixation of the haptic, either using a suture or the Yamani's flanged IOL technique. Now, this again, there have been isolated incidents of opacification of the hydrophilic acrylic lenses that have been reported, although the etiology is not too clear, and these children might require an IOL exchange or an explantation. Thank you for your attention.
Thank you. They did a great job, Dr. Akhila. So covered most of the things. I would like to take question with Dr. Sujata Goa on this. When would you recommend secondary IOL implantation, Dr. Sujata? And in children with microcornea.
Madam, you need to unmute, madam. Unmute.
Yeah, in children with microcornea, I wouldn't give any IOLs. Especially if it is less than any microcornea. By definition, microcornea should not get IOLs. It's so microcornea IOLs are a no for me. And secondary IOLs, again, theoretically we can give it anytime after 2. But what happens is that if we are planning a second procedure, I would like to be very sure of the IOL power calculation. So the younger the child, the more uncertainties in the IOL power calculation. So I would definitely wait till the maximum growth period is over, and do it after 5 to 6 years of age, because that is the time for the maximum growth of the eyeball. So we can get a better estimation of the IOL power calculation. Yes. That is my practical approach.
Yes, very relevant. Dr. Murli?
Yeah, I have 2 questions, in fact. One is to the panel. One is that if these children with microcornea, when they become adults, some of them have been left phakic. So let us say you have a 20-year-old operated cataract surgery in early childhood, and now he has a microcornea, let us say corneal diameter of 9.5 or so. I mean, how would you and he wants a lens. So would you go ahead or would you do a UBM to measure the sulcus diameter, or how should we plan? Let us say he's a 20-year-old now. So the corneal diameter is around 9.5 to 10. So what to do in these patients? Most of my colleagues have gone ahead and implanted the lens, but should we be doing a UBM and checking for the this thing, or how should we proceed?
Yeah, you're right. Actually, the bag does grow, and you should do a bag diameter. And yes, we have also implanted IOLs in such cases, and that is the best approach.
Right. Thank you. Shall I go on to the next speaker, Murli?
Yes, ma'am.
We have with us Dr. Frederick Motopa, who is a senior consultant in pediatric ophthalmology and adult strabismus from Arvind Eye Care Systems based at Pondicherry, and he's going to talk on comprehensive DVD management. On to you, Dr. Frederick.
Thank you, madam. Am I visible and audible?
Yeah.
Am I audible?
Yes, yes, you are.
So I'll be talking about DVD management, just a small introduction, and then I'll go to the management as such. Oh, God. So the classical description has been hyperdeviation, abduction with excitotorsion, and there have been types which have been described like manifest or latent, unilateral or bilateral. And important to know that it doesn't follow the Hering's law, whereby you don't have a hypo in the non-fixing eye. And etiologies, much has been described, but still the exact etiology is not known. The various theories have been proposed. As far as the clinical features are concerned, mainly it presents at 2 to 5 years of age, and it's commonly associated with infantile esotropia, latent nystagmus, amblyopia, amblyopic eye, and very rarely with infantile exotropia or DRS. And usually it is bilateral but asymmetrical, and sometimes it also presents with the head tilt, which is in the direction opposite to the eye with DVD. And clinical examination is mainly it is manifested by doing the cover uncover test, and it's recommended that we use a Spielman's translucent occluder. In manifest DVD, usually the fixating eye is covered, so the other eye takes up fixation, and in latent DVD, dissociation is done, and then the eye under cover moves down once it is uncovered. So coming to the measurement, as we know, based on prisms are used, and cover uncover test is repeated over the prism until no movement of the DVD eye is noted. So in case of bilateral DVD, this needs to be repeated in each eye separately. And they are graded as mild, moderate, and severe being more than 20 prism diopters. And inferior oblique overaction, as we know, is a confounding factor with respect to DVD. And usually we see the fundus to see whether there is any extortion to really differentiate it from inferior oblique overaction. Coming to the treatment aspect as such, what about when do we observe latent DVD, especially more than 8 years of age, where they have crossed the amblyogenic age groups, and you usually observe, or small abnormal head postures of small degree, which is not a significant cosmetic blemish, then we also observe. And non-surgical optimal spectacle correction we give. There have been reports where you change the fixation pattern by giving a few plus correction in the fixing eye, so that the fixation turns to the DVD eye. And injection of botulinum toxin has also been described in the literature. So coming to the surgical part as such, the main indications being if the DVD becomes very visible, more than +2 deviation in adduction, or if it's very large and it is manifested, abnormal head posture, or there is a significant cosmetic blemish. So different surgical options have been described in the literature, but only 3 muscles have been tackled: the superior rectus, inferior oblique, and the inferior rectus. So common, we use the superior rectus large recession 7 to 10 millimeters. Other procedures which are done in the superior rectus include the Faden procedure, where you do a minimal 3 to 5 millimeter recession and then you put the sutures, or you can do a Y splitting of the superior rectus muscle. With respect to inferior oblique, the most common surgery done is the anteriorization of the inferior oblique, which was described. And inferior oblique can also be weakened. And also there is anteriorization with some amount of resection when you have a large DVD. And inferior rectus also, inferior oblique is also transposed nasally for more effect. When coming to the inferior rectus, resections are done depending upon the amount of DVD and also inferior rectus tucking. So factors to consider: visual acuity, laterality, symmetry, inferior oblique overaction, and recurrence, because DVD is quite recurrent, and you have to know the type of intervention which has already been done. So different scenarios we have discussed and described, and how it is being tackled. In unilateral DVD, you usually tackle the superior rectus with a hangback, plus or minus a posterior fixation suture. When there is no inferior oblique overaction, then we usually tackle the superior rectus bilaterally. When it is less than 15 prism diopters, around 7 millimeter, and if it is more than 15 prism diopters, 9 millimeter is recessed. In case of asymmetry of more than 10 prism diopter, then we do the 9 millimeter in the greater eye with the greater DVD, and 7 millimeter in the eye with the lesser DVD. When there is inferior oblique, when there is inferior oblique overaction, then of course you tackle the inferior oblique, and the most common surgery being the inferior oblique anterior positioning. So care should be taken never to place the inferior oblique in front of the IR insertion. And in case of asymmetry, there is a resection also done on the inferior oblique and in the eye with greater DB. Coming to recurrence, which is common, as I told you, if we have already done a SR recession, then we either go for re-recession, which is if it is done less than 7 millimeter, then we go for bigger recessions like 9 to 14 millimeters. And if it is less than done already, it has been done 7 millimeter, then we go for inferior oblique overaction, anterior positioning, or the inferior rectus resection. So following post inferior oblique recession has been done, then we go for anterior positioning. If inferior oblique anterior positioning has been done, and if the SR is not tackled, we'll do a SR recession. In case of myectomy, which is not usually done now, but which the patient would have undergone previously, then we can consider a SR recession. What if both the muscles are tackled? And so then there is a difficult scenario. So when considering that small SR recession has been done and inferior oblique recession has been done, then we do a IO anterior positioning or a SR re-recession. In case of anterior positioning already being done with a small SR, then we do a SR re-recession. And in case of myectomy, we go for SR re-recession. When large SR recessions have been done, along with IO recession, then we go for inferior oblique anterior positioning. In case of inferior oblique anterior positioning has been done and myectomy has been done, we plan for IR resection. So usually DVD management, the recurrence is also a very important part which we need to consider and discuss with the patient and then decide on the type of intervention that we are going to do, so that at the end of surgery, the patient also understands the long-term prognosis. Thank you.
Thank you. Thank you, Dr. Frederick, for the very detailed talk. Any one question we can take, Murli, we can ask Dr. Savleen some question before we move on, because we have many more speakers yet.
Yes, I have a question for the panel. Is there a consensus on managing a Helveston syndrome, that is A pattern with bilateral superior oblique overaction with DVD? The panel, any of the panel could answer.
I think we could ask Dr. Savli. He has not been talking at all. We've never given to be specific each of them. He's not there now. Okay. Anybody else?
I would like to add.
Savleen, I mean, your take on this?
Okay. Yes, Dr. Shweta.
Yeah, in cases with large A pattern and DVD, I would like to go with correcting A pattern as well, and then going for the DVD. So if there is SR overaction, I would like to go for SR recession with Y split in these cases and bilateral symmetrical. And in case there is asymmetric DVD, I'll go for asymmetric SR recession. So this will be, and if there is an exotropia, I'll correct the exo or iso, I'll manage that also.
Thank you. Thank you very much. And paucity of time, we should move on. Would like to request Dr. Jyoti Matalia, who's again specialist in pediatric ophthalmology, squint and neuro-ophthalmology, and heads the department at Narayan Nethralaya, the main hospital. And and she would be talking to us on the when and how of lateral rectus periosteal fixation. On to you.
Yeah, thank you, Dr. Chitra. And for inviting me for this session. I'm going to be talking on lateral rectus periosteal fixation, a very specific surgery and a specific procedure for a definitive indication. And what I am going to be talking on primarily is when and how. So let's understand, when can we do it? In the literature, we have studies that show the treatment in oculomotor, that is third nerve palsy with residual exotropia, in Duan's retraction syndrome in presence of to achieve a satisfactory alignment due to anomalous LR function, and for upshoots and downshoots. Then what about the how? In this, the lateral rectus muscle and the adjacent periosteum 5 millimeters below the lateral orbital rim is exposed. The LR muscle is then attached with a non-absorbable suture, and then a suturing of intermuscular septum is done to create a barrier. So let's go and see where has this been published. So in 2000, there are multiple case reports which talk about it, starting with Welles in 2004, who showed that it is kept for surgeries like third nerve palsy, Duan, sensory exotropia, and aberrant innervation of vertical recti. What they showed that it definitely causes a permanent disinsertion of the muscle from the globe and is also reversible. It was Morad et al. Who showed that when you are doing a third nerve palsy and use it for this particular indication, you also have to do medial rectus resection, medial transposition of the vertical recti, so that you need to tackle the exotropia which is there, because now you're totally removing the lateral rectus function. So you need to add something else to get the eye to the midline or medially. Then the AIM study by Sharma et al. Showed that the advantage of doing a periosteal fixation with lateral rectus and a partial VRT will help improve the abduction and also get a binocular single vision, because they compared the groups with and without the partial VRT. And then we had a study where Naga Subramaniam showed that you can actually do this procedure through a skin incision, providing more room and avoiding extracorneal fat manipulation. So these are the various techniques. So let me try to show with a case what is the importance of the when and the how. So this was a case that came to me with a left eye exotropic DRS, already having undergone surgery. You can see the face turn. And in primary position, also there was a left exotropia. So if you look at the 9-gaze picture, you will see there's an adduction limitation of -4 and an abduction limitation of -2. Incidentally, we got the old surgical notes which show that the LR was already recessed by 9 millimeters with Y splitting. MR was resected and then finally recessed after putting on adjustable. So what we did is, yes, our very classical family album tomogram scan, that is, look at the old pictures showing that whatever was done pre and post surgery was absolutely the same, indicating that this particular patient had a left DRS with anomalous LR function. And as I said, this is one indication to go ahead. So we went ahead and did the same surgery. So let me show you the steps of this particular condition. So since we had 2 split LR bands, we first went in and did first we did a FDT, which is very important. And that showed us that the muscle was actually tight. You can see the eye is not being able to adduct. And we did a limbal incision because we have to hook those 2 separate bands. A traction suture is very important, as seen here. Then we were able to isolate the superior LR band. We sutured it and disinserted it. At the same time, then we found the inferior band also, again sutured it and disinserted it. And after getting that, we tied the 2 bands together so as to have one particular bands together. Then we did the lateral periosteal fixation, located the lateral orbital rim, as you can see here. And then below that, we passed with a non-absorbable proline suture through the periosteum. You can see as you're pulling it, there is no movement indicating it's gone through the periosteum. After that, the 2 bands we held together and broke all the additions. We don't want this band to stick back. So this entire mass of the 2 bands was then sutured with this particular non-absorbable suture, as you can see here. And then the overlying tenons were sutured. This provides a barrier between your sclera and the particular the periosteum to prevent it from hooking back. And then the limbus was sutured again. So the final outcome here, as you can see, was a fully corrected head posture, orthotropia for distance and small XT for near because he already underwent resection and then recession. And then the advantage was not only that the eye face turn was improved, the eye was straight, but he also had improved binocular single vision as is shown. So now let me tell you the importance of how. This was a 33-year-old patient who came to me having undergone DRS surgeries, good vision in both eyes, as you can see here, had undergone multiple surgeries, 9 surgeries already done for him, but he was very unhappy and he wanted to get his eyes straightened. These are the multiple surgeries. And if you can see, there were 2 surgeries done on the left eye, but right eye have been done right from 2009 to 2019. And the final surgery was done where the LR was fixated to the periosteum. Now, if you look at his eye condition, you'll see there's a left face turn of 25 degrees. When he fixes with the right eye, there's a left hypertropia. But when he fixated with the left eye, you can see as in this picture, RXT with the right hypertropia. Extraocular motility showed a -3 abduction, but a -5 adduction, narrowing of a palpebral fissure in the left eye on adduction. There was excyclotorsion. And the amount of squint was 14 PD exotropia with 16 PD right over left. In all these cases, I prefer to do an MRI, and we noticed that there was something attached in the right eye. Hence, I decided that we have to go ahead and explore. And the idea was exploration of the right eye, the right eye lateral rectus, the medial rectus, and inferior oblique. You've seen the muscles are so many touched in all aspects. Unless you explore, we not know what to do next. So this is the surgery. As you can see, the FDT is tight, lateral rectus, and we found that the inferior oblique muscle was adherent to the lateral rectus and displaced downwards. We also found that the lateral rectus was adhered to the globe 10 millimeters and 15 millimeters behind the limbus and adhered to the inferior orbital margin, which was surprising. And as I mentioned, IO was found anomalously attached. So this is the reason why the IO was pulled down. He had got an excyclotorsion. They had done a lateral orbital wall fixation, but actually not clearly made a barrier, because of which it got adhered to the sclera and to the inferior orbital margin, telling us that it's very important where you suture your lateral rectus. Otherwise, these issues can come up. We went ahead and did an inferior oblique myectomy and also did a lateral rectus. We disinserted it, totally cut it, and then put it way below the periosteum. And at the end, he had no face turn and he was finally happy at 10th surgery. So just an important take-home points, lateral rectus periosteal fixation is very effective if the indication is appropriate. And I feel it works best for DRS with anomalous lateral rectus function, because once you've disinserted it, lateral rectus is no longer acting, but you can definitely use your vertical recti to improve the abduction. In 6 nerve, you have to associate it with other conditions, other procedures like the medial rectus, plication, etc. Preoperative MRI is preferably done, and you should have a trained radiologist who can help you find this. Like in my case, this muscle is sutured under tension so that we don't want it to fall back on the sclera, and about 5 millimeters below the lateral orbital margin for a version muscle. And it's easier to do those cases. Like in my case, you can see hooking the lateral bands and all that becomes very difficult. But remember, for a recessed muscle, it has to be sutured way below, about 15 millimeters behind. The intermuscular septum, which is there, should be sutured in such a way that there's a barrier between your sclera and the lateral rectus so that it does not adhere back, or you'll have the same problem as my second case. And remember, there is a good role for VRT because it can all help improve the abduction. Thank you so much for your patient listening.
Thank you very much, Dr. Jyoti. That was a wonderful talk. Murli, do we take a question or we move on to our next speaker?
Madam, just one very short question. Has there been any situation in which you have had to reverse, because it's considered to be a potentially reversible procedure? So has there been any situation where you have had to reverse a LR periosteal fixation?
No. So as I said, it's a very specific surgery to be done for a specific indication. So I will do it only and only if in my case, when I want to do it for an anomalous DRS. I do not prefer it to do for third nerves. That's one. Many times they say reversible, but it's actually very difficult to go back and get. Like even we talk about plication being a reversible surgeries, but they say in the initial phases, within the first few weeks, if you do, you're able to reverse. But later on, I don't think so it's possible.
Thank you.
If I can add, Dr. Jasprit actually described anchoring it to the lateral palpable ligament instead of to the periosteal wall. So that is a little easy if you're planning to just start off with your surgeries. I totally agree that if it's an anomalous LR, you have to weaken it. So you can anchor it to the periosteum or to the palpable ligament. Theoretically, the palpable ligament would be easier to find if you want to reoperate, but I haven't done it. Like a reoperation, I haven't done. But
and one more point I can add is if you want, you're not very sure, you can take the help of your oculoplastic colleagues to be able to go into the periosteum. So don't hesitate if you're not really sure how you can hook it. Because you may feel you've gone into the periosteum, but not truly, then it wouldn't survive. It wouldn't help. It'll again come back and touch your, fall back onto your globe. Okay. Thank you.
Shall now go to our next speaker, Dr. Arun Sakrati, who's again cataract, pediatric ophthalmology and strabismus surgeon from Samprati Eye Hospital and Spin Center, Bangalore. And he's going to be talking on Brown syndrome, my take on optimizing outcomes. On to you, Dr. Arun. Can you unmute yourself?
Yeah, I'm unmuted. Am I audible?
Yes, yes.
Yeah.
Yes.
Yeah. So first of all, I would like to thank Chitra Madam and Team ARC for this opportunity. So my take on Brown syndrome. Brown syndrome, as we know, is basically a limitation of elevation in abduction. So the basic problem in Brown syndrome, just 1 minute. So the basic problem in Brown syndrome lies in the superior oblique tendon and the trochlear complex. In congenital cases, the tendon itself is short, or it can be inelastic, or it could be in acquired cases that could be cysticercosis of the superior oblique muscle, which again can cause Brown syndrome. So there are few features which are necessary for making a diagnosis of Brown syndrome. Defective vision in adduction, defective elevation in adduction, less elevation defect in the midline, minimal or no defect in abduction, and this is important, minimal or no superior oblique overaction, that's important. V pattern deviation with divergence on abducens and restricted forced ductions. That's again a very important feature for Brown syndrome. These are the less consistent features. So going to the management, very rarely investigations are necessary in congenital cases, mostly in acquired cases, especially where cases secondary to juvenile rheumatoid arthritis or cysticercosis, then the investigations may be necessary. Imaging, especially in the cysticercosis, it will be very useful. MRI scan can be done, which can show the cyst clearly. Even in congenital cases, before surgery, we can actually do an MRI to know what is the anatomy in the area. USC B-scan again is useful when we are suspecting a cysticercosis. So coming to the management as such, my preference will be in most of the cases, just masterly inactivity. You don't need to do anything much except in cases where there is an abnormal head posture, or if they are suspecting the development of amblyopia. See, these are the only two indications where surgical intervention may be necessary. Otherwise, most of the cases, if the child is straight in the primary position and doesn't have any abnormal head posture, we don't need to do anything. We just observe and see how the child progresses. Whereas in acquired cases, usually local injection of corticosteroids like Tricort or dexamethasone may be necessary. And of course, the most important is a systemic treatment. Suppose if the child has a JRA and the systemic treatment of the condition or even the cysticercosis, systemic treatment will be necessary there. Coming to the surgical management, the only absolute indication for surgery, as I told, is any congenital case whereas the loss of binocularity is there or there is a possibility of development of an amblyopia. So these are the only two conditions where absolutely surgery is necessary. Otherwise, relative indications will be deviation in the primary position, hypertropia, or if the child has a very severe abnormal head posture, or there is a very unacceptable downshoot in adduction. Coming to the options, the surgical options, we can do two things. One, either we can weaken the superior oblique or we can lengthen the tendon itself. Weakening the superior oblique, the superior oblique tenotomy is the procedure. However, this tenotomy is actually not a very good procedure, and I think most of us have stopped using this procedure as a choice of treatment. Prior to a few decades ago, probably this was the only treatment done for a Brown syndrome. So here you just cut the tendon and leave it. The main problem here will be the iatrogenic supraoblique palsy, because you are just cutting the supraoblique completely, and there is a normal inferior oblique which is overacting there. So iatrogenic supraoblique palsy is the main problem with the tenotomy. Whereas now the preferred method will be the tendon lengthening procedures. There are basically three tendon lengthening procedures we do. One is the silicone band spacer, other is a chicken suture, and the third is a split tendon lengthening. So just see the three procedures. So this is a superior, silicone band spacer. So basically what we do is we cut the muscle into two parts, the tendon. And in the tendon, we are implanting this silicone banded 40 number silicone band, which is used for the retinal detachment surgery. So that can be used. So thereby we are increasing the length of the tendon. So because as I said, in congenital Brown syndrome, one of the main thing is the short tendon. So we are basically trying to lengthen the tendon. So usually we do about 4 to 7 millimeters of lengthening depending on the tightness of the muscle. So here again, the force reduction test is very, very important, because the end point at which we have to stop the lengthening is determined by the force reduction test. We have to match it with the other eye. Other option for this is something called this chicken suture. So here, instead of placing a tendon, because the silicone band, which is a foreign object, then there is a possibility of extrusion or other complications because it's a foreign object. So instead of that, we can use a suture, a non-absorbable suture can be used to produce the same effect. So here again, after splitting the tendon, you are putting a suture, non-absorbable suture, same about 4 to 7 millimeters, depending on the thing. So the advantage of this is it can be adjustable on the table. You can just tie a loose knot, adjust it as per your requirement to see that the force reduction test becomes normal. And a more physiological procedure, which most people I think are practicing nowadays, is to do a split tendon lengthening. So here you have seen this is a supraoblique tendon, and this is the normal. If this is a normal length of the tendon, we are going to lengthen it to this much by splitting the tendon. So you just make first you make a slit in the middle of the tendon, and then you make two cuts on the other side, so that you can attach this part of the tendon to the this part. So you are basically lengthening, increasing the length of the tendon. So again, here this can be like you can adjust this amount of lengthening that is necessary by determining what is this on the force reduction test. So force reduction test is very important in Brown syndrome management. So in summary, most of the cases of Brown syndrome may not require any treatment, especially if the primary position there is no deviation and there is no risk for loss of binocular vision, or there are no signs of amblyopia. Tenotomy with the chicken suture or a split tendon lengthening is technically easier and is actually the most preferred choice nowadays for most surgeons. And acquired cases are usually managed medically and may not require any surgical intervention. Thank you.
Thank you. Thank you very much, Dr. Samprati, that was a wonderful talk. Murli, would you want to take a question or shall we move on?
Yeah, I just had one question for for Dr. Arun and the panel. One is an acquired Brown syndrome, especially that which is showing superior oblique inflammation on MRI, either myositis or trochlitis. Is there a role for pulse steroids, or would you prefer an intralesional, or would you go ahead with oral steroids, and what systemic workup should you be doing in these patients?
I personally don't use systemic steroid. Most of the time, the local steroid is sufficient to take care of that. Systemic steroids may be indicated only if the systemic condition warrants the use of systemic steroids. I request other panelists to kindly comment.
Yes, Dr. Savleen?
I definitely believe in the role of steroids in acute conditions after an immunological and rheumatological workup. You want to give them local or you want to give them oral? I think there are a lot of varying reports, but yes, definitely there is a role in acute conditions because they seem to go with.
MS Madam and SG Madam, any comments?
Let me just add, so after the steroids, and they can also recur. So that is something to watch out for. Even though the imaging may not pick up inflammation, you have to watch them closely because they can recur. One other treatment that has been also suggested is that you can, after the initial course of steroids, you can even take them and put them under anesthesia, like an EUA, and do a vigorous exaggerated FDT. And sometimes that is all that may be necessary to sort of break the adhesions and resolve the condition. I've had 2 patients who did well this way.
But I think they are prone for recurrence.
They are prone for recurrence. They are, yeah.
Now, there is a small change in sequence. Dr. Manju wanted to be talking before you, Dr. Shweta, maybe because of the continuity of talk, okay? So we shall now go on to Dr. Manju, who's a consultant ophthalmologist in cataract, strabismus, and neuro-ophthalmology from LV Pair, Hyderabad, and she's going to be talking on planning a second strabismus surgery where no records of the first one are available. On to you, Dr. Manju.
Thank you so much. And thank you, Dr. Chitra, for inviting me to participate in today's webinar. So am I audible and my slides are visible? Hello?
Yes, all good, doctor. Yes, audible.
All right, thank you so much. All right. So we'll be, I'll just quickly go through in my 6 minutes about planning a redo squint surgery when we don't have records of previous surgeries. And this is something we commonly encounter in institutional practice, but also sometimes in private practice as well. So in itself, redo strabismus surgery can sometimes be challenging, and it's more so when there are no previous surgery records. So some of the things that I would go in a stepwise manner, or rather use clues to rely on, is first is the history. So asking the parents, how was the deviation before the first surgery or the second surgery, if they've had more than one. Then is the family album tomography or the FAT scan. This is really useful because looking at old photos of childhood will give us a clear idea of how, whether the deviation was, there was an inward or outward deviation to begin with. Then third is the examination findings. So looking at the ocular motility, the deviation, the limitation of motility, especially in any particular gaze. And then also assessing if there's any presence of conjunctival scarring, which we would very often be able to pick up, we'll very often be able to pick up on a slit lamp examination. Then as indicated in MRI, as most of you would be aware, we do sometimes need to use neuroimaging as an additional tool. And then finally coming to the intraoperative findings, exploration, and then planning the procedure. So these are the 5 steps that we can take one after the other in evaluating a patient and then planning a redo squint surgery when we don't have any previous records. So I'm just going to quickly go through 3 cases which I encountered. And this is one child who presented after 2 strabismus surgeries elsewhere. As we can see, she's got a large right exotropia, and there were no records whatsoever available with the parents of the previous surgeries. So again, starting with the histories, the parents reported that the eyes were turned in, or there was an inward deviation before the first squint surgery. Then I asked them for any old photos, to which they said, oh, we don't have any old photos. Then on examination, there was a limitation of adduction, as you can see in the right eye, about -5. There was presence of conjunctival scars, both in the medial and the lateral fornix in the right eye. And so then we went through some dialogue. So this is how the dialogue went. I asked the parents, can you get previous records from the hospital that she underwent surgery? And they said, no, doctor, they don't give us records. Like, okay, any paperwork that you have from there? I thought I could just see somewhere some notes written. And then the patient just gave me all the bills of the surgery. Then I said, how come you don't have old photos? It's like, you know, we're in the smartphone era. Everyone captures photos right, left, and center, including selfies. What about birthday photos? So the answer was, oh, they were in my old phone and the phone was stolen. Like, okay, then I said to them, we'll have to open the area around the muscles, see where it's located, and then make a plan. And then they were very clear. We don't want surgery on the good eye. Only make that bad eye straight. So I had very clear indication, like I had to just wave my magic wand and get the eye straight. So this happens very often with either parents or even young adults where they don't want the good eye to be touched. So in this case, I went ahead with an MRI orbit. Of course, as expected, or rather thought of, because the way the limitation of adduction was present in the right eye, the child did not have the medial rectus present at the insertion. It was detected at mid-orbit. However, the previous surgery was like almost 3 years ago. And with the COVID pandemic, they sat at home for 3 years, and then now they turned up to get the eyes fixed. So the medial rectus, though explored, could not be found. And the lateral rectus was found at an insertion of 14 millimeters from the limbus in the right eye. So I went ahead and did some more recession and did a supramaximal recession of the lateral rectus, and then a partial tendon superior and inferior rectus transposed medially to the medial rectus. So of course, I didn't have the didn't want to go ahead with full tendon and, you know, getting into all sorts of other problems with her. So she does have a limitation of adduction and abduction in the right eye, but looking at her primary position, she looked pretty good at 6 weeks after surgery. So here we can see that there is some limitation of adduction and abduction, though now she's having dense amblyopia in the right eye, for which she's undergoing further treatment. So this is one place where neither the old photos help nor much of anything helped other than exploring and finding the muscles. So this is another case. It's a 19-year-old young female who had previous strabismus surgery in childhood. They were just not sure of what the eye position was before the first surgery. So I again asked for old photos. And then I got a range of photos. This is the first, this is the second, this is the third, this is the fourth. In none of these photos, or maybe in some of these, she's looking straight ahead. But here, as you can see, she seems to be looking slightly. So also here. So she pretty much looked ortho to me. And now she presents with this large angle exotropia of the left eye. So again, the old photos were really not conclusive. So they thought that maybe she had an inward deviation. The FAT scan was inconclusive. The motility was full. There was no scarring evident on slit lamp. So I thought, is this a consecutive exotropia? Is this a residual exotropia? So the plan was basically based again on the exploration, and the lateral rectus here was found to be at 14 millimeters from the limbus. So it was recessed previously and looked like it was a case of residual exotropia. So the lateral rectus was re-recessed a further 4 millimeters from the 14, and the medial rectus was resected. And this is her post-operative picture. So she's fairly cosmetic from what she was before. So I'm just going through the last case now. This was a patient who came with bothersome vertical diplopia. He was a patient of thyroid eye disease. He had had some squint surgery elsewhere. He complained of double vision and said it was no better. There were no records. And the old photos before and after surgery just looked similar. He just looked the way he was. So as for following the protocol for thyroid, I first did an oculoplastic consult, and they said, oh, he's not in the active stage. He does not need decompression. Just go ahead with the squint surgery. So this is the way he presented with left hypotropia, and there's limitation of elevation of the left eye, as you can see here. Also, although the depression is full. So also the right and left case. So I again repeated an MRI, found this super huge inferior rectus on the left side.
Time is up.
Yeah. And so again, in this case, I needed to do an exploration. So this is just my last 2 slides. And there was excessive scarring at the inferior rectus muscle, as probably some of you can see here. But the muscle was just found at about 7.5 millimeters. So I don't know, it was just recessed about 1 millimeter or so. So I further went on to recess it by 6 millimeters with a half tendon nasalization. And then again, balancing the defect with the contralateralized superior rectus recession. So now he's diplopia free in primary, but does have some in reading position. So just to conclude, redo surgeries with no records can be sometimes really challenging. Patient counseling is really important in these cases about the expectation and having realistic outcomes. So this extra time with patient counseling helps. Use of imaging, as we all know, to look at the muscle positions, and always get a good assistant and have a lot of patience while dissecting. And this all can be a recipe for a successful outcome. And this is my dinner. So this is just a recipe photo. And thank you very much for a patient listening. Thank you.
Thank you. Thank you very much, Doctor. Dr. Savleen, I have a question for you. How do you define the role of ASOCT in these cases?
Ma'am, personally, I think they are a gold mine for a surgeon who's doing a reoperation, especially the cases like Dr. Manju said, excellent outcome you got, but we are confused. It's a residual exotropia, it's a consecutive exotropia, and ASOCT or maybe the ultrasound with a higher magnification probe can actually tell you what surgery was done, quite up to the accuracy of say 2 millimeters. For the third case that you showed, the motility limitations, in those scenarios, the ASOCT does not, is not that beneficial because of the motility deficit that the patient has. You cannot image the muscles very well. But rest, for me, in a reoperation, doing an ASOCT adds to the information that I have from the photographs almost in 100% of the cases, because it will tell you up to about 1 to 2 mm with accuracy that where the muscle is. So yes, personally, I really like to do it in all cases of reoperations.
Thanks.
Thank you. Thank you. So we shall now go on to thank you very much. Paucity of time, we have to move on. We have our next speaker, Dr. Shweta Chaurasia, who's again an associate professor from PGI Chandigarh, and she's going to be telling us a different outlook to what was discussed today, cerebral visual impairment and overview. On to you, Dr. Shweta.
Is my slide visible?
No.
But you need to share screen on the Zoom window.
Yeah, I'm clicking
the
on
green
the
button.
Is it? I think. Can I ask the other speakers to speak? Meanwhile, I see there is some privacy issue with.
Dr. Dipti, are you there?
Yes, ma'am, I'm here.
So shall I ask Dr. Dipti to talk, Shweta? Till
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Mr. Sunil, could you please guide her? Yes. So we shall now go on to Dr. Dipti, who is again the Senior Consultant Pediatric Ophthalmology and Squint from Joshi Eye Institute, Hubli. And she's going to be talking on another interesting topic, intermittent exotropia, pencil push-ups, dichoptic exercises or surgery. How would I choose? On to you, Dr. Dipti. That's a very important topic.
Good evening, everyone. So thank you, Chitra ma'am, at the outset for giving this wonderful opportunity. My topic is dichoptic exercises, pencil push-ups or surgery. What do we choose in a case of intermittent exotropia? So intermittent exotropia differs from other type of strabismus in that we just don't see the amount of deviation or what is the sensory status. There are multiple factors to see in this before we decide on the surgery. Like in case of motor status, it could be control and the amount of deviation. In sensory status, it could be both the distance as well as near stereo acuity plays a very important role. In addition to that, the age of the child, the patient, his requirements, quality of life also matters before thinking about the surgical or the treatment aspect. So there are two sets of opinions with respect to pediatric ophthalmologists. There is a set who says that early surgery may be needed.
I'm not able to share because I don't know, there is some privacy issue coming. How?
So early surgery may be needed in few of the children to prevent them progressing into a constant exotropia, whereas there are other set of people who say because there is it is an intermittent exo and some amount of fusion is still left in some children, non-surgical measures can be tried to some extent and the surgery can be pushed. Well, that definitely is the biggest debate as to what to try and what to do. Before we select whatever modality of the treatment, the most important is optical correction. We all know very well that myopia and anisometropia are to be treated fully to prevent the accommodative convergence and to treat the intermittent exo part. The question mark lies with hypermetropia, but the point to be noted is if any hypermetropia more than +4 to +5 is present in the child, that itself can be a retinal blur and that can result in IXT per se. So adequate treatment of hypermetropia and the thought process upon that is also equally important. The newer set of treatment which has come into intermittent exotropia, especially with non-surgical aspect, is the vision therapy. Now, vision therapy, there are multiple steps which have been practiced with respect to vision therapy. It is not just an anti-suppression training. There is refractive adaptation. It stimulates accommodative and fusional convergence. It makes the patient aware of eye movements, his diplopia, and hence the anti-suppression modalities do take place. It can happen with respect to a simple gyroscopes, or it can happen even with the fusional, the vergences can be increased by using your single rule adapters, or the Brock string, a simple Brock string can be used with the same. The newer ones of vision therapy includes the computer-based exercises, which can be office-based procedures, or a part of it which can be given in the home also as a management aspect. Now, when do we actually give vision therapy to the child? That is especially when there is a small angle intermittent exotropia of less than 20 to 25 prism diopter, good to moderate fusion, especially in the cases where there is an associated amblyopia and anisometropia, basically because in addition to treating the intermittent exotropias, the fusional vergences, we can even take care of the amblyopia in the same sitting. The vergences can be taken care of very well with respect to the convergence insufficiency pattern of intermittent XT. And it is a boon with respect to post-surgical residual intermittent XTs. There are multiple studies which say that if intermittent, the vision therapy, if it is done adequately for a period of 6 to 7 months, it actually takes care of both positive vergences, the suppression treatment happens, and the patient may regain a good control for a period of next 2 to 5 years per se. But if there are so many positive points and if there are so many indications for performing vision therapy, why is it still an underutilized scenario? Well, if you think a trained personnel, an orthoptist or an optometrist has to be trained to perform a vision therapy, that is a bit difficult in tier 2 cities. Understanding of the children, well, if this is a scenario, if a child presents at this age, he actually fits into all the scenarios which is needed to perform a vision therapy, where it is good to moderate fusion and the child has a mild IXT, but the understanding of the child is not fit to perform a vision therapy. Motivation of the parents. For intermittent, the vision therapies, it passes through phase 1, 2, 3. It's not like we can shift the child from phase 1 to phase 2 to phase 3, but until and unless the child develops, first he develops a good vergence, he develops a good suppression, anti-suppression, only then he can be shifted to phase 2. So till he attains that mark, he cannot be shifted to phase 2 or phase 3. In some children, it may take 6 months. In some children, it may take 9 months. So motivation of the parents and the compliance of the parents is very important when we perform a vision therapy. Financial strain. In a place like Hubli, where people travel 100 to 200 kilometers to visit us daily with respect to the strabismus of the children, to ask them to come weekly twice may not be feasible in many of the children because of the financial strain and the traveling. Definitely, vision therapy is not a substitute for the surgery. So then comes the alternatives, and they are patching, over minus, and the pencil push-ups. So definitely the over minus, these three basically takes care of all the things which vision therapy used to do. For example, like over minus takes care of accommodative convergence, the patching takes care of suppression treatment, and the pencil push-ups to some extent does take care of fusional vergence. I agree, they are not long-standing treatment procedures. They do not take care of our stereo acuity the way the active vision therapy takes care. But if I am making my child, any child, wait for a surgery for a definite period of time, in those periods, these are some cost-effective alternatives which I can initiate in those indicated children of the vision therapy. Despite all these measures, if the child shows an increasing angle of deviation, deteriorating control, or a decrease in stereopsis, well, there is an addition indication now with respect to the newer papers which have been published, that is improve the quality of life. So this is one more. So it doesn't depend whether definitely it is a small angle ET or some, even in case of moderate control, we may have to perform surgery because of the need of the patient per se. So despite all these measures, if these indications are seen, that is when a surgical indication happens for IXD. So with conclusion, the question was, how would I proceed? If it is a case of intermittent XD with a very well controlled, stable angle with no symptoms, there are some people whom I've still kept in observation group, which is still a question mark for many of the people who may be present here. Then definitely with a close follow-up. But most of my patients remain in this good to moderate control with variable angle plus or minus symptoms with a good stereo acuity. If they are really affordable, they are ready, a compliant patient who are ready for home-based therapy, who are ready for the active office therapy, vision therapy with or without over minus is what I prefer. Else, if I think that they may neglect the child and who may progress, yes, the over minus with the patching is what, plus or minus Brock string, I do send them home with that. The final is poor or deteriorating control. In those, I prefer surgery. One last line, if it is basic, I prefer recession resection. If it is divergence excess, I prefer bilateral augmented LR resection. If it is convergence insufficiency, I prefer bilateral MR resection. With this, I end my session, but then this is definitely an enigma, and each doctor who is present over here may have his or his own protocol of managing IXD, which just suits their patient better would be the best thing. Thank you.
Thank you, Dipti. That was a wonderful talk. Very nice. The best ones for the last, huh?
Thank you, ma'am.
We shall now go on to our last speaker, is Dr. Shweta. Shweta, you can connect now? Yes.
Is my slides visible now?
Yes, visible. Yes, yes.
Yes, yes.
Thank you, madam, for the opportunity. My 6 minutes talk will be an overview of an important pediatric ophthalmology entity, cerebral visual impairment, which has been on rise due to increased ICU care. Improved ICU care, I mean. Cerebral visual impairment is a condition which is characterized by visual impairment and results from perinatal or postnatal visual processing injury to the visual processing structures and pathways of the brain that cannot be explained by ocular abnormalities alone. This terminology has evolved from the terms cortical, it's not going forward. Yeah, it has evolved from the term cortical blindness, which is acquired bilateral injury to occipital cortex in developed brain. Now, the injury to the developing brain of neonates and infants differ from the developed brain injury, and because these children are rarely blind, and hence the blindness term has been replaced by visual impairment. Since the both the higher visual pathway and subcortical structures are involved, so the cortical was replaced by cerebral. Cerebral visual impairment is illicit. Cerebral visual impairment is caused by damage to the retinogeniculate striate pathway, which receives information from the cone-rich areas of the brain and traverses via optic tracts through optic radiations and primary visual cortex, which is area number 17. Many a times extrageniculate visual pathway is preserved, which receives information from the peripheral rod-rich areas of the brain and traverses via optic tract, superior colliculus, pulvinar nucleus to parastriate cortex, which is area number 18 and 19. It is important to understand that the ability to detect movement is central to the function of superior colliculus, and hence this explains why some of the CVI children are sensitive to moving objects rather than stationary objects. Now, coming to the etiology, perinatal asphyxia, postnatal asphyxia, hypoglycemia, brain injury, infections, hydrocephalus, malformations, and neurometabolic disorders are some of the common etiology. The common pathophysiology is hypoxic ischemic encephalopathy. Here, the hypoxia causes a disrupted autoregulation and reduced cerebral blood flow, which causes ischemia and cascade of events, which results in CVI. Now, the severity of brain injury in HI depends on the severity and duration of hypotension and the degree of brain maturation. Authors have described the brain injury based on the gestational age, which is the cutoff level is 36 weeks. Children less than 36 weeks, the preterm children have injury to the periventricular area because of the ventriculopetal blood supply, whereas the term infants more than 36 weeks have injury in the parasagittal areas of the brain because of the ventriculofugal blood supply. Now, characterizing the visual deficit, they may have decreased visual acuity, visual field deficit. The higher order visual processing deficit includes visual perceptual deficit, visual motor deficit, and visual cognitive deficit. Now, these children have vernier acuity selectively affected in infants and children, and this is a sensitive measure than grating acuity for quantifying the visual deficit. Coming to the clinical features of cerebral visual impairment, CVI problems are dichomatized into ventral or Watt pathways and dorsal stream or Ware pathways. Now, coming to the dorsal stream impairment clinical features, they have impaired or fluctuating visual attention. These children seem to be visually inattentive. Then they may have photophobia or glare. They will just close light to bright light, or they may be light gazers. They will keep on looking towards a lighted source. Then many children look away while reaching objects. This is a very common feature in these CVI children. They may have optic ataxia. That means the patient have difficulty completing visually guided reaching task in absence of other cues. They make multiple attempts, fall short or overshoot or even touch surface. Then they may have simultagnosia. It refers to the inability to perceive more than one object at a time. Then they may have dyskinetopsia. It means that difficulty viewing fast moving objects, like they may face difficulty in moving traffic. Then they may have impaired distance vision. Then they have perception, particularly in the lower field because of the involvement of the parietal lobe. Then they may have impairment in spatial orientation and navigation, like this is a drawing by a CVI child with eyes at the bottom and mouth at the top. Then they may have impaired visual search. Then other neurobehavioral signs of dorsal stream include need for light, need for movement. They may have color preference, and red and yellow could be the color preferred by these children. They may show latency for giving visual response. Then they may have apraxia of gaze, like this child who is making eye movement. If you could see, this child cannot make saccades, and the child makes head movements in order to shift the gaze. Then they may have atypical visual reflexes. Ventral stream impairment includes impaired recognition of face, objects, shapes, and letters. They may have impaired visual memory, impaired orientation. Now, coming to the refraction, children with ROP has myopia, whereas children with periventricular leukomalacia without ROP have hypermetropia in combination with astigmatism. Then children with cerebral palsy have hypermetropia as a common refractive error. Then accommodation dysfunction is also common in most of these children. Coming to nystagmus, they have roving eye movement. Children with periventricular leukomalacia display latent or manifest nystagmus. Then coming to the optic disc, normal disc is seen in 56% of the cases. Optic atrophy is seen in 24%. Optic nerve hypoplegia without atrophy is seen in 8%, and combined hypoplegia with atrophy is seen in 12%. Many children with periventricular leukomalacia have pseudoglaucomatous disc. Then exotropia in early life is a commoner presentation, whereas children with periventricular leukomalacia present with esotropia. Many children have dyskinetic strabismus, where esotropia changes to exotropia on momentary basis. Then tonic down gaze are often seen. Like in this child, you can see there is a tonic down gaze. Now, coming to the electrophysiology studies, many authors have found that abnormal flash VP predicts a negative outcome, but many authors have also found that VP has a low positive predictive value. A bad VP result does not necessarily mean a poor visual outcome. Coming to the role of imaging, in preterm children, the periventricular leukomalacia is a common finding, which could be focal adjacent to the frontal horns and trigones. It could lead to ventriculomegaly. Many of these children have thin corpus callosum. Then if the necrosis is extensive, then it could lead to cystic encephalomalacia. Then they could also have general matrix hemorrhage. Whereas in term infants, because of the watershed involvement, they may have watershed predominant pattern, which extends to the cortical gray matter, whereas some of the children may have basal ganglia prominent pattern involving the deep gray nuclei. A word about relationship between visual dysfunction and cerebral damage in CVI. Residual vision in CVI has been correlated with degree of periventricular leukomalacia, thinning of corpus callosum, size of lateral ventricle, and involvement of peritrigonal white matter, because the tracts of the optic radiations and connections to visual association cortex travel within the periventricular white matter. And periventricular leukomalacia and preterm is often associated with impaired visual processing because of the damage to the optic radiations, which are often close to the trigone. So to conclude, the current trend suggests that the incidence of CVI is rising, and diagnosis and characterization of the underlying visual impairment throws a greater challenge. Prediction of visual functional outcomes and road for recovery is even more challenging, and establishing a connection between how changes within the eye relate to visual impairments in CVI will be important for developing effective rehabilitative and education strategies for individuals living with this condition. Thank you.
Thank you. Thank you, Dr. Shweta. That was a wonderful talk. Anything, Murli, before we conclude?
Yeah, I have two questions. One is, what is your take, Dr. Shweta, and the panel members on strabismus surgery in these patients?
Can you stop sharing your screen, Shweta? Yeah.
Yeah, so what is your take on strabismus surgery in these patients? Strabismus surgery is often considered to be very, very challenging because what you mentioned is kinetic strabismus, and also that the results in these patients are quite unpredictable. So what's your take on strabismus surgery in these patients? Of course, either you can answer or SG Madam is also there.
Yeah, in children with in stable vision, we do surgeries, but we never leave exotropia. We do little bit of undercorrection in esotropia because this may lead to a consecutive exo or exotropia over a period of time. We do, but not in all the patients. Those patients, when we know that this patient has some amount of vision, residual vision, we go for surgery. This improves the this improves the confidence of the patient's parents also. And this boosts the parents' confidence, and it has a positive impact on the overall parents. Though we are not sure we are going to improve fusion and stereopsis in these children because of the damage to the visual structures of the brain, but I have operated like around 5-6 cases in these children, and the outcome is good. But you have to select patients, definitely.
Yeah, true.
So should any other question from the panel, or shall we conclude?
Madam, 2 grand round cases are there.
Oh,
I just wanted to quickly add that, yeah, tomorrow being the World Prematurity Day, so we are going to see more and more of CVI because of non-recognition of, neonatal hypoglycemia. We're going to a lot of ROP, premature kids surviving. Kids who are in our system, we're going to have a lot of challenges with rehabilitation because we don't have good systems for, customizing OT, PT, vision therapy, schooling, etc. in these kids. So there's a lot of work to be done in this area. And that was a great talk, Dr. Shweta.
Thank you, madam.
We shall now go on to our grand round cases. And the first case would be dealt by Dr. Vibha Badrinath. And it's going to be commented on by Dr. Akhila Ramkumar. So on to you, Dr. Vibha.
Good evening, everyone. So today I'll be presenting a grand round case, and the moderator is Dr. Akhila. So it was a 35-year-old female patient who presented to the clinic with chief complaints of outward deviation of both the eyes since 5 years of age. She gives some history of squint surgery, which was done in both the eyes 3 years back, but there were no records available with the patient. But she says that she noticed worsening of the squint after the surgery. On ophthalmic examination, the best corrected visual acuity in the right eye was 6/6 and in the left eye 6/7.5. The intraocular pressure was normal. In the right eye, a nylon suture was seen in the supraronasal conjunctiva. The rest pupils, anterior segment and posterior segment were normal in both the eyes. Coming to the squint examination per se, sensory examination on word 4-dot test for both distance and near, there was left suppression. Stereopsis was measured on RANDOUT and was found to be more than 600 seconds of arc. Motor examination showed a left exotropia, which on cover test was going into an alternating exotropia. On prism bar cover test, this was measured for distance to be around 75 prism diopters basin and for near to be around 80 to 85 prism diopters. This is the 9-gaze photograph of the patient. Here we can see that there's mild adduction limitation in both the eyes. The rest extraocular motility was normal. And because the patient had history of previous squint surgery, we looked for a scar on the conjunctiva. And we can see that there was a scar seen in both the eyes nasally near the insertion of the medial rectus and also the nylon suture which was seen in the right eye. And because of this, we repeatedly asked the patient for any previous photographs which were there before the surgery. And she showed a very old blurry photograph which showed she had an exotropia even before the squint correction. Then we went ahead with an anterior segment OCT to find out the insertion of the muscles, the current status. It was seen in the right eye, the medial rectus was at 5.6 mm from the limbus. But in the left eye, it was at around 9.64 mm.
Oh, ma'am, I think we lost the video.
Yeah. Excuse me. Not got her? Network is bad? Oh, that's so sad. Mr. Sunil? She's off.
Ma'am, her connection is stuck. I stopped the sharing.
Oh, okay. Shall we start with the next speaker till she gets back? What, Murli? I think we'll do that, right?
Yes.
Yeah. Has she got back? No. Okay. So, not got back yet. Okay. So we shall then
summarize the piece.
Yeah, I know. So sad for the young girl.
Yeah, actually, this was I was not the primary surgeon who was involved in this case, but this patient actually came with a history of exotropia. But what did not fit into the jigsaw puzzle was that she gave history of exotropia, but then the patient was actually operated on bilateral medial rectus, and there was a scar on the medial rectus, and she had a exotropia. So that was what was not fitting. So madam, actually Smita madam had operated on this patient, so she went ahead and ordered for an anterior segment OCT. As Dr. Sablin rightly said, anterior segment OCT gave almost a precise positioning of the medial rectus. Left eye medial rectus was a little behind, but if you look at the medial rectus of the right eye, it was almost 5.5 millimeters, which was at the original site of insertion of the right medial rectus. So this patient, the plan was to explore the medial rectus and see, and if possible, if it was a resected muscle, then FDT gives you a very good clue. If it's a tight medial rectus, then you need to put it back into the original insertion and then plan the other muscle surgery. So she actually, went ahead and then explored the medial rectus. But then the SSOCT, I think Vibha, she can share the OCT pictures for comparison. It gave clue to the that the muzzle was a little resected, because the thicker insertion site and the contour of the anterior and the posterior coat gives you a clue whether the muzzle has been recessed or resected. And this case, actually, planning is more important. Plan A or plan B you should have, in case if this muzzle is, you're not able to hook the medial rectus, then what would be your next plan? So that is what is important when you're doing a resurgery and when you don't have records which are not fitting into the history. So that was the idea of actually making her present this, and SSOCT is an excellent tool in getting an idea as to how to plan your resurgery. So,
okay, thank you. Thank you very much.
Slides.
Yeah, we shall now go on to our next grand round case. Dr. Abhinaya will be presenting and moderated by Dr. Kavita. Dr. Abhinaya Valiyappan. Is she there?
Yes, ma'am. Good evening.
Okay. Can you start?
Yes, ma'am. So good evening, one and all, and thank you for the opportunity. Today, I'll be presenting a challenging case of a 4-year-old male child who came to us with complaints of sudden onset diminution of vision in the right eye for 10 days after sustaining a firecracker injury. He was taken for a consult locally immediately after the injury, where he was told to have right eye traumatic hyphema and cataract, and he was managed conservatively and referred to a higher center. Coming to the examination, the visual acuity in the affected eye was hand movements and was unable to follow light with a dull reflex on retinoscopy. The intraocular pressure by finger tension method was raised in the right eye and measured during the exam under anesthesia to be 18 millimeters of mercury using Perkins applanation tonometer. The other eye was within normal limits. The anterior and the posterior segment of the involved eye will be discussed in the subsequent photographs. So coming to the diffuse illumination picture while examining under anesthesia, the right eye showed a traumatic cataract with pre-existing rupture in the anterior capsule, inferior 3 clock hours iris tear with iridodialysis, and a localized nebular corneal scar. Owing to the poor view, a B-scan ultrasonography was done for the posterior segment evaluation, which was within normal limits. Both the axial length were comparable, and there was no evidence of foreign body or posterior globe dehiscence noted. Hence, a working diagnosis of right eye traumatic cataract with inferior iris sphincter tear, status post firecracker injury was made, and the plan was to do a right eye lens aspiration with anterior vitrectomy with or without intraocular lens implantation and with or without inferior pupilloplasty under general anesthesia with very guarded visual prognosis. The parents were explained regarding the same and the other surgical risks associated, which is a key step in such cases. An on-table digital biometry was also performed, and 3-piece lens was kept in case the IOL was implantable. Coming to a short surgical clip. So after the 15-degree side entries were made at 10 and 2 o'clock, 360-degree synecholysis was performed using the iris patula, and we went ahead with the lens aspiration through the pre-existing AC tear. Mechanical stretching of the iris edges was made for adequate exposure, and an MVR entry was made closer to one edge of the tear, and a 10-0 double-ended polypropylene suture was passed through the other tear edge, and a 26-gauge needle is passed through the MVR port side through the other edge, and the polypropylene suture was passed through the 26 gauge by a railroad technique and pulled out through the MVR entry side. After this, using the intraocular forceps, an intraocular segment of the suture was pulled out and a suture loop was created. The free end of the suture the needle was cut from the free end of the suture, and 4 throws of the suture was passed through the suture loop, and the ends were tied to oppose the iris tear edges. And after the adequate apposition was achieved, the excess suture was cut using an intraocular scissor. This same procedure was repeated again under ample viscoelastic cover. So after this, we went ahead with posterior capsulotomy and anterior vitrectomy and implantation of the 3-piece intraocular lens in the sulcus after assessing the adequacy of the support, and the ports were sutured with tenovicryl. So the postoperative day 1 was uneventful. There was no hyphema or AC reaction. The IOP had normalized, and he's currently under our follow-up under steroid tapering and antibiotic cover. So for pupilloplasty in our case, we did the single pass 4-throw technique proposed by Dr. Agarwal et al., which is an effective self-retaining and self-locking method, which is a modification of the Cerebral method. Here are a few other techniques which can be used, which includes the McKennell suture, the Cerebral knot, iris circlage, and modified Cerebral sliding knot. A few of the illustrations are represented here, taken from the AIOS. And as discussed, a few points to keep in mind include, it's better to do in aphakic or pseudophakic eyes to avoid trauma to the crystalline lens. Miotics can be used for better exposure of the iris edges of the tear. Here we did a centripetal mechanical pulling, which helps to loosen and stretch the tissue in preparation for suturing. And it's useful to do under ample viscoelastic cover to avoid trauma to the cornea or the crystalline lens. A few known complications include hyphema, iridodialysis, corneal edema, and worse complications like IOL decentration, dislocation, glaucoma, or retinal tear. So coming to the cataract part, it is important to assess the nature of the injury, and need for VR surgeon backup should be well planned preoperatively. Iridolenticular adhesions, if any, is to be completely tackled for adequate exposure, and also to identify if there is any iris tear, which can be tackled simultaneously and very effectively as done in this case. Dye-assisted rexes or the banded technique can be used in cases of pre-existing tear, which will act as useful aid. So the banded technique was proposed by Chaudhary et al., where an iatrogenic rexus is created aside the pre-existing tear with a band of tissue in between, a band of capsule in between, so that which acts as a support even if you're planning to implant an IOL, provided the posterior support is intact. Coming to the lens aspiration, low aspiration, vacuum, and bottle height parameters are important. Despite the age cutoff, it is beneficial to do PPC and anterior vitrectomy in all traumatic cataracts in children. And IOL implantation should be based on weighing the risk-benefit ratio. I would like to thank AIOS and SN Pediatric Ophthalmology team for the opportunity. Thank you.
Thank you. Thank you. That was a very crisp, nice talk. Any question to be, yeah, you have to discuss her. Yeah.
Thank you, Abhinaya. Nice presentation. So we just wanted to share this case because of a few things. Like in trauma, we don't have a very controlled situation. We have issues with iris many times associated with the cataract management. So we should anticipate and keep a backup plan for managing iris at the time of a cataract management whenever indicated in children, to avoid multiple surgeries. That is first point. Second point, to manage the cataract, if the anterior capsule already has a dehiscence, better to avoid Japan blue, because many times it seeps through and stains the posterior capsule, which makes your rest of the surgery very, very tough. And if the capsule is ruptured, like in this case, you try to have a minimal hydro and remove. And then once you remove the cortex, you have a better visualization with the retro illumination, and you can trim the rest of the anterior capsule as indicated. And for the management of iris, you need to make sure there is no defect or there is no tissue loss, so that you get a good approximation. And it is a very gratifying surgery if you're able to do it in the same setting. Thank you.
But I don't understand why you can't use Trifen blue. I didn't agree with that discussion.
Not that you can't, but many times what happens, ma'am, through the zonules or anything, it stains the PC. Once PC gets stained, the view gets very disturbed, ma'am. That's the experience. I mean, you can use
into the vitreous cavity actually, and the retro glow is gone. So after the visualization of all the structures become challenging. That's the similar to, you know, using less amount of blue in a coloboma. So the vitreous gets it gets stained.
It's just a word of caution. I mean, sometimes you do have to use it, but if we
use limited quantity, don't use it copiously. That's all.
Anything else, Murli?
Yeah, madam, I had a question for Dr. Meenakshi R. Tirunelveli. Two questions actually I had. One is regarding this band technique. I mean, SG madam and of course KKV and Meenakshi madam can answer. Have you ever had to yag this band in the postoperative period? That was my question number one. Because band technique is very useful because it prevents the optic capture. So have you ever had to yag these bands in the postoperative period? That was question number one. Question number two is, we saw many patients who have had multiple strabismus surgeries. So have you encountered any patients with since surgically induced necrotizing scleritis? Because the incidence becomes more common with repeated strabismus surgery. So your thoughts, madam?
Yes, this bad one had it, but better do it earlier than waiting too long, because then it becomes more calcified. As pediatric cases, they become thicker very fast. So I had one or two instances where we had to yag the anterior thing. And regarding, since we had one case, one pediatric case also, we had a surgically induced necrotizing scleritis, and initially it was thought as an ACCO and conjunctivitis, and then we had to put steroids and everything, and it resolved. And the other case was, and it went for a small staphyloma also. So we have to be very careful an immediate post-op when anybody develops redness or what, severe congestion, redness and discharge, not to take it lightly, thinking that it is just conjunctivitis or increased inflammation. So you should, it's not uncommon, very, very, very rare. Maybe you will get 1 or 2 cases in your whole career, but you should be alert to it. That is my this. And all these traumatic cataracts always trauma, like these things, we should counsel for long-term follow-up. Any pediatric cataract, we tell them, but these people don't turn for follow-up. And then even angle rescission, actually, even if you don't have any perfect surgery also, like this is a more complicated case, so they may come for follow-up. Sometimes it's just plain blunt trauma, but at 40 years, one eye alone can go for GOA. So angle rescission is another thing that we should keep in mind, all these blunt trauma cases. And anybody has done this small, smaller size IOL, wanted to ask me, the secondary IOL, all of us were like microcornea, you are not placing usually.
10
So
millimeter, I have
makes
used
10
this
mm
Oropi diol.
IOL.
Oropi diol I have used.
Yeah. You have used.
Overall 10.5, I think, no, sorry.
Is the diameter, yeah.
Yeah.
And any glaucoma going that
Glaucoma,
ROP
I think
IOL,
we're missing a lot of glaucomas, because most of these glaucomas come around 10 years.
And they don't come for follow-up.
Yeah. So I think I'm going to conclude. It's been a great session, and goes without saying that we had such top-class expert panel and amazing speakers. It's just that we had too many topics, and I think we could not appropriately utilize discussion time with the expert panel and learn something more than what the speakers had to convey. So I think this was a big lesson for us, that we should not crowd it so much. And thank you so much, dear expert panel, and every single speaker. Like, everybody gave their life and soul in this topic, and 6 minutes were just amazingly packed with information. I definitely have to thank Murli, as always, because contributes so enormously to pediatric and neuro-ophthalm that, and I'm sure all of you would agree, he's quite an asset. And of course, we need to thank my ARC team, and for whatever support they all give all the time to me. And my thanks are due to the AIOS admin headed by Kripal. My thanks are due to Sai and Numerotech for the emails which reach your inbox. My thanks are due to Mr. Sunil. He disappeared for a brief time because of some tragedy in the family, but he's an amazing support for all our webinars and does a lot of background job for all of us. And finally, I think, Mr. Sunil, can you put that video to Entode for the kind of support and the sponsorship they've done for every single webinar of mine in these last 2.5 years or more. And I think this is the most appropriate video, which you're going to see very briefly, because this is a Myopia Awareness Week. And this video is very much in connect with what we are trying to spread word around. Mr. Sunil, are you there? Yes. Can you play the video? Thank you very much. And I think we all have done big inroads into myopia treatment also. So I think kudos to all the pediatric ophthalmologists of our country for bringing that difference. And thank you all. Thank you so much. Go back and have your dinner, and thanks for today.
Thank you.